Jeff England will both be absent of the meeting and not able to be on remotely. Let's go to the agenda. I don't see any public here this time, heavens. We must have solved all our problems, but nobody's here. They only show up when there's a problem. All right. Approval of the minutes. I'm looking for a motion on January 28th minutes.
So moved.
I second.
Motion by Abby, second by Clint to approve the January 28th, 2026 board minutes. Any discussion? All in favor?
Aye.
Any opposed? Any additions to the agenda? Or I'm looking for a motion to approve as is. Do I need to put something in executive session? I can just add that in executive session, can I, Brandon? Okay.
So long as it's part of the motion, then go.
It is part of the general motion, yes.
The notes to the board, was that intended to be an executive session?
No.
Is it intended to be brought up? I
Yes.
thought,
I'm gonna be bringing it up.
is it on here anywhere? You might need to make that.
Yes, it's there. I saw it on the board packet, my letter.
It's in the beginning of the finance committee.
Thank you.
Any other changes or additions? Motion to approve the agenda.
I make a motion to approve the agenda. I'll second it.
Clint makes a motion to approve the agenda as written, and Cole seconds. Any further discussion? All in favor?
Aye.
Any opposed? Motion passes. Okay, we have, what, 30 minutes, 20 minutes now? So our education is,
We need to go at 3:00, so if we could go past them and then.
Yeah. so our education, which is a Gallup survey, folks are going to meet with us at 3. So we're going to jump over that for a little bit. And why don't we go right to the chief of staff's report while are you ready, Doctor?
You bet.
Can you be ready?
Should it be on the back row? We got lots of open seats up here.
Even when the CT scan gets back. What was that?
Lots of seats up here.
I'm gonna be in and out, so. Okay. Since we last met, we have started the Nocturnus program, and I think Dan will speak on to that as well. The feedback I'm getting is it's working, it's going well. I have not had any experience with it. I don't know, if you've heard anything different, Dr. Turk, but I've talked with quite a few ER docs, and they're okay with it. So I don't know if we've used the PEAT yet, so I'm unaware of that. We're gonna talk about the survey. Anxious to see those responses, anxious to see we parse out the providers, anxious to see what that actually shows, because we're never happy, so I think we may bring it down a little.
We can never make you happy, is that what you're saying?
That's correct.
Wow.
So, not just me, there's others, all right?
I'm understanding.
So, and since we last met, there's 2 new procedures that have been performed by Payne, which this valley's never seen before, which is fantastic. Next week, we have procedures for loop recorders, and cardiology is also going to be starting another one in the coming months, but these are things we've never seen here, Star Valley. So it's amazing. And in the last 24 hours, I've been in 2 people's bellies, open bellies. And I had 2 new medical students start yesterday. And so this was 10, 11 o'clock last night over in Montpelier for one of them. And if you'll just indulge me for a minute, these are medical students that have never seen an open belly. They haven't seen, what we did, bowel resections and sick people, and they're trying to live. And both of them went fine, but I looked at their eyes across the table, and they're just bug-eyed. They don't know what they're looking at. This is crazy. And I was reminded of a couple things, so this is what I am in the morning, and I'm on and off the phone with nurses, and so I wrote a couple things. So indulge me for a minute, if you would. I wrote, there's something quietly extraordinary about being a physician, is what I wrote, but I think it applies to all of us in this room. Something quietly extraordinary about being involved in healthcare. Every day, people allow us into the most vulnerable moments of their lives. Moments of fear, uncertainty, pain, and hope. They place their trust in our hands before anesthesia, in our judgment during crisis, and in our words when outcomes are unclear. That trust is not something we earn once. It is something we must honor every single day. In surgery especially, we stand at a unique intersection of science and humanity. We use precision training and discipline, but what our patients remember most is whether we were steady, honest, and present. Skill repairs tissue. Presence restores confidence. Compassion steadies families. It is easy to focus on the weight of call schedules, complications, documentation, and administrative responsibility. But beneath all of that is something rare. We are allowed to relieve suffering. Few professions offer that privilege on a daily basis. To care for another human being at their most vulnerable is not simply work, it's a calling, and remains one of the great honors of a lifetime. So that was 1 or 2 a.m. this morning. But I think it plays for all of us. Now, we're going to talk about finances. We're going to talk about all this. It's a business. I get it. Let's not lose focus on what really matters here and what we're doing. That's all I have.
Well written, you ought to be tired more often. Okay, continue to move on in finance. Consent agenda, anybody have, we're going to be bringing some of that out, I think, so why don't we just hold the consent agenda until we've had our finance committee report today. And let's just spend a few minutes on this under new business, item A, review of governance structure. You each received my letter. Didn't bring a written copy here, hang on. What I want to make sure out here, I'm not going to reread the whole letter. It's part of the packet. 46. 79. It came to my attention, as I said in my letter, that we may not be getting all of our questions answered. And so, as I talked about this with Dan, I was thinking that, a few years ago, as I said in the letter, Dr. Gordon and I had some discussion, probably the best way to say that, about length of meetings. And I think we kind of came to the way we ought to handle that, to try to keep the meetings as short as possible. And that's what I reviewed in the letter. So what I'm hoping is that, I kind of thought everybody knew that, but I've decided probably not. There was, we had 3 new board members in the last couple of years. So they may not have seen it. And I don't remember whether Abby and Mindy and Cole remember those discussions and what we kind of decided. But this is as I remember it. And so I want to make sure in the end that every board member feels comfortable to ask any question in a general session. Now, to shorten our meetings up, it used to be, and I remember years ago when I was on the board, I was on the finance committee and I'd hear it once, and then they'd come into board meeting and they would regurgitate everything that I had just heard in the week before or whatever. And so we've slowly evolved so that we don't really need to do that. We have committees to take care of the guy. And so hopefully, if you have a question of a committee, please go to that chair or one of the members. See if they can answer that question prior to board meeting. If it gets successfully answered, great. If it doesn't to your liking, then, and you feel like it needs to be brought up at the board meeting, my discussion with Dr. Orton at that time is I'm all about making sure we have enough time to answer questions. It's not the length of the meeting that's important to me, it's that we get all of our questions answered. So if any of you are feeling like you have unanswered questions, and I know you've seen the emails from Mindy, she had some. We're going to respond to those today. I think Cole's going to respond as the finance committee chair on those. But anybody in the room can be asked a question. Or ahead of the meeting, if you'd like to contact a member of the administrative team, I know that all of them will answer questions. You might loop Dan in, as I mentioned in my letter, just so he understands the context of everything. And I know for myself, I like to see the big picture of everything without somebody else's rose-colored glasses filtering it. So anyway, any thoughts or comments after you read that? I mean, hopefully I stated what at least what I remember our procedure. And if we need to change what I've written, I'm fine with that. But if there isn't any discussion, we're going to move on and assume that you've all been re-educated as to the method to get questions answered. Thoughts or comments?
I have one thought that I want to add.
Okay.
Sure, if you don't mind. Obviously, it's my role and my team's role to provide information to the governance structure, which involves the committees. And in my experience over the last several years is that people that are not on the finance committee, there's some real questions that it's hard to glean from just the report or even the notes. And so Marl and I spoke about how important it is for board members that may not be part of a committee that want a little bit more detail to work with their fellow board members that are on that committee to make sure that the right questions are being asked and answered, the level of accountability that they expect is there and exists, within the finance committee. And if there is something that they feel needs to be that bubbles up to the general board meeting, then that can be certainly specifically talked about in the chair's report. And my responsibility is to be transparent, but transparency relies on whether or not some information is ready. There's a readiness issue. And sometimes we as administrators are working on something, we don't have all the answers, but what we can present at a particular moment in time at that finance committee, if it's ready, we're good to go. So we don't want to give half-baked answers. We want to make sure that we have all the relevant information so that if something does go to the public, they're not hearing a half-baked answer, which creates more confusion than anything else. So the governance structure to me is very sacred. You know, we should use that governance structure to make sure that all the relevant information is ready and is presented in such a way that people can ask the right questions and we can provide the right answers. And if we don't have the answers, that we're able to take the necessary time to get the correct answers back to the to the right forum, and then make sure that the board members feel like there's an avenue to vet their own personal questions that they have concerning any subject matter. So I am a big believer in the governance model. I do believe in streamlined meetings. I do support the chair's position that if something does need to be questioned or asked at this board level, hopefully we've had enough time to talk about it, or at least we have there's been behind the scenes conversations about making sure that we've got the right information coming to the board. And at the end of the day, that's all that really matters, is that correct facts, correct analysis, a correct understanding of an issue is brought to light. And if that remains our objective and goal, then the board can be a high-performing board.
Comment. I feel like when things were really volatile a few months back, everything was supposed to be funneled through Dan, and then I'm reading your interpretation of that letter, and it's more like go directly to the committee chair. If they have the answer, they'll give it to you. They may loop in and
You can go directly to Dan too.
Dan, yeah, but
I
mean, if you're, I'm feeling like you're directing it to the committee because they're doing the heavy lifting. Maybe they know something Dan didn't hear about. Just kidding. I don't really know. It's just,
Could be.
It's an interesting thing.
Let me
I'm not
tell
on
you
the
how I
finance
handle
committee, and so I wouldn't even know the questions to ask, It is a fact. You guys have a multi-hour meeting and it takes me about 15 minutes to read every word of the agenda. I know that there's a disconnect between, what I know, what I think I know.
I hope
But just
I
to make
mentioned
questions, it's just, if she's been in finance committee, so she can see stuff between the lines on the finance. Would we agree? And I don't, so.
Probably so.
So I don't think she's trying to say that she doesn't trust the finance committee. She just has more questions. She's got a financial background. So trying not to speak on her behalf. Is it true she should go to Cole as the committee chair, or should she ask Dan, who then says, respond to Cole? Like,
I think it's a choice. Cole?
So, Abby, I remember what you're talking about there as far as that conversation. The way I took it is that we were to go to Dan if we were going to ask something of the admin team. So if we were asking, if I wanted to contact Scott and say, hey, Scott, this is the question I had, that type of thing. Dan wanted to be copied in on it, or we wanted to funnel it through Dan. But if it was going to a board member, I think you can go directly. If you had questions on the finance committee, you can go to me. I do my best to answer them, and then if we need to get Dan or Scott involved, that's the way I took it.
That's the way I hopefully wrote it.
Yeah.
My writing isn't as good.
No, your writing's not poor. It's just a little bit different than
May
what
not
I
say
verbally
exactly
heard,
what
but
I
I've seen
hope.
something in
Yeah.
writing, so what's our
And that's
standard?
why I put it in
Yeah.
writing.
I don't think everything needs to be at board meetings, but I also think if something comes up, it's like really heavy on your heart, and you're like, this is important for people to know that we don't intentionally have conversations off the book so that the public isn't aware of them. But I also do agree with the opportunity to rumor or clarify that.
If a board member feels that going straight to Dan or a member of the administration first is the way to do it, I like it from the horse's mouth. So if I have a question, I think you could ask any one of those guys over there I call them, or gals. Excuse me, I meant all the staff. And that's just the way I operate, because I want to hear it directly. And I do loop Dan in usually and say, hey, do you mind if I talk to so-and-so? I think it's good for him to have the context of everything, and leaving him out isn't the right thing to do. So I think it's an either or. Depends. I think it's up to the board member to decide. You certainly have access to any staff member, I think. Dan, I think you have access as well as any of us to any member of the staff. And if you feel like that's the better direction, go there. If the finance committee chair or a member of that committee or the quality committee can answer the question to your satisfaction, great. What we want to do is make sure there's answers to every question. And nobody should feel concerned or even afraid of bringing it to a public meeting. Transparency is all about a publicly square discussion. I mentioned that, but I like them. I think they bring out, everybody has a different perception. I think they bring out those different perceptions. And sometimes I go, oh yeah, I had never even thought of that. So what I'm hoping out of that is we have a procedure that is open. We can ask questions. We can have trust between the board and administration. I think that's pretty vital. And that I still have the adage of trust but verify that I don't know that everybody appreciates, but that's just kind of the way I run things. So anyway, other thoughts or questions, comments? Go.
Just one more thought there. Honestly, Abby, to your point, I guess as a committee chair, I would welcome the other board members to ask questions so that I know what's of me, so I know what's on their mind. If you got something that's pressing, it's a hot button topic, I would appreciate you guys saying, hey, why don't you look into this, dig into this a little bit more? And if we already have, I can maybe speak to that, but if we haven't, that's something that we can be paying attention to and address in the next committee meeting. And I think that's important because we try to vet things, but we're not perfect, and it's always good to have another set of eyes on it. So yeah, if there's something that we need to address, by all means, bring it up. Mindy and I actually had a conversation not that long ago, and I think we addressed a lot of the questions that she had. But again, yeah, I think that's great. I think it just makes us better. So.
It is, and recognizing this whole thing, I know a number of the questions we're going to discuss today came from Mindy. She and I have had a conversation too. Mm-hmm. I went and sat down and said, hey, what's going on? A lot of these I've seen in the minutes, but not everything has been in the minutes of the finance committee meeting. And so, and I assured her that, and then I wrote the letter after we talked that, hey, this is all about open trust and open communication. So at least that's the way I would like to see it. Clint, anything? Okay.
I smell coal threatened to kill my children if I stepped out of line. So wow. Boy, that's a heavy hammer.
That was it. Yeah.
There's gotta be one of them if I didn't, right?
I think we're almost at the top of the hour. I don't know that I can get this exactly at 3, Andrew. Do we know when they're coming
not
on?
on.
What's that?
They're not on yet,
Okay.
so just keep going.
Why don't we have the quality committee? You have your report, Abby. Let's go down to there and jump over finance. We'll come back. It may take a little longer than we have.
Highlights from the board quality meeting. We've done some new shifting on the program we're creating putting the metrics into. It is called, Sadie, what is it called? MIDAS. And so a lot of information was the first time reporting. So in all reality, the graphs aren't super informative. 3 months from now, when they've got 4 months of reporting, it'll be a lot more valuable. So with that being said, people are really looking at great goals, throwing off goals that don't make sense, but I'm always impressed with that. I saw in Dan's CEO report that he's gonna touch on the care center's facility assessment, so I'll skip past that. But kudos to the care center, and I'll let him brag about them in more detail when he gets to it. Because of the switch in reporting, a couple of metrics maybe look worse than they were, but it's because we didn't used to synthesize all the information from, like, let's say Falls Care Center versus post-surgery. It's accurate. I think saying this right. So as a first-time reporting, it might look like we really forgot how to catch Falls or work with that, but really it's just new standard, and then we'll see how things look going forward. All the departments continue to push the limits on ways to improve things that they can do. Something really cool I think I want to mention was the therapy department. Shannon Linford spoke, and they found that if they don't pre-authorize a certain procedure, things weren't getting paid, and they took it upon themselves to reach out to the billing center, and they're kind of stop that loss, prevent, they're getting the pre-authorizations done. Like, there's obviously like a backlog of those, but I thought it was really cool to see the department saying, like, what can we do to help with the revenue cycle problem? And there's only so much they can do at their desk. If it's a co-insurance or co-pay, or saying, oh, these are just sitting in backlog, and the gals at the billing center, it's so many steps away from them that it's maybe not like top of their mind first priority. But now, they significantly reduced the money that's outstanding in that, because they're making sure to do the pre-authorization, and they're collecting, they're doing the work to collect what's sitting there uncollectible at this moment. So I felt like it was a drastic improvement. And then I'll just touch a couple of process improvements. The patient estimates continuing to get better and better, and they're still looking at ways to improve that, but it's an exciting change. Again, helping revenue cycle before the bills hit, or before patients have something to anticipate. I think that's always really great.
And this is still a therapy department.
No, this is all over the hospital. I think they're within like $300. Is that the rule? They have to be within $300 of the estimate, and before a couple of systems weren't communicating correctly, and it was way off. But they've moved the pendulum to say, like, hey, we're getting quite close, and just finding ways to make sure all the systems are communicating with each other. And if somebody's had a procedure done at another hospital, that we're recognizing that towards the deductible. You totally get this with your line of work, and everybody knew these things, but they weren't easily coming together. So they've been improving those, and then taking a look, they'll audit it, and they'll say, this is what we anticipated to be, this is what it actually was in sync. So they're really getting better at those numbers. So the EMS reported on that status zero. And was it 17 minutes of status zero in the last quarter? Does that sound accurate?
I haven't looked.
I don't want to actually put a legitimate number out there, but we all know status zero, it's when there's not a ambulance that would be able to respond if a call came in. A call didn't come in, but it was like in the teens. That number was like in the teens. And so I just wanted to say, I think it's awesome that they're tracking it. I think that it's very reasonable, like for our valley. Obviously, if I'm like the person that's without 17 minutes, I probably already made that decision. I'm like heading to the hospital because I can be there in 15. But I think I'm impressed with the numbers. I just wanted to bring that up.
Remind me how status zero works.
So if we've got like 3 ambulances and there's 3 wrecks and they're all on a wreck, and then a 4th call comes in, like, we wouldn't have the ability to get it there. If there's a not fatality or multi-injury, something going on, I don't know exactly how they record that, but usually they always send as many people as they can. They kind of be the one that can go access the other areas. They're getting the logistics worked out, but if something happens at the tail end of the valley, they might be bringing a unit from Afton. One thing, like transporting somebody from Alpine to Afton, because of the QE level, it challenges like the number of rigs that we have able to operate, which is hard. But one of the QI projects was not using ambulances to like get Joe Blow home from their surgery. So that was a QI project to use resources outside of hospital personnel to make sure that they have a ride home. And if they don't have a ride home, that we can offer certain different services, and Sadie, it's been implemented, it's going well. I don't think that, it's going pretty good. It's going well enough, they're not overutilizing the ambulances for that service. So that's positive. So they thought of these things. Yeah, I think that is my report.
Any questions?
So, just one that popped in my mind. So with the Medicare cost reports and the big emphasis of pay, how do we maximize every benefit we possibly can? Like who, is there one person that's kind of at the head of spearheading that? The admin, or is, like, where does that reporting? So Scott, okay.
Yeah, you're gonna hear a lot about it next month in the finance committee, as well as our board meeting and strategic planning session.
Anything else? Is that Gallup that's joined us?
Yep.
And Caleb?
Yep, that's me.
Mr. Chair, maybe you can give Trevor a little bit of a brief introduction of Caleb and the process that we've led up to get to this point and provide that context.
Give us the background.
All right. Well, first of all, I want to thank Caleb for joining us from Gallup. He's a senior workplace advisor with Gallup, and he's been very helpful in just helping us understand our engagement scores. One of the things that Dan and I talked about last week is that the benefit of working with Gallup is that we actually have what we feel like is meaningful data that we can use and that we can actually create action plans on. In the past, we've been engagement. It's kind of like, well, what do we do with this information? And as I hope you'll see, as Caleb goes through this, you'll be able to see that there are some recommendations and best practices that we want to implement. And so I'll turn the time over to, actually, before I do that, a little bit about what we've done so far. We've met with our leadership team in Gallup, and then we've also met with the department directors and shared with them their scores. So each department, if they had enough people participate, they have specific action plans that they'll be able to create from the engagement scores that they have for their departments. And it's not all the same. Some departments do better than others in certain areas. And so anyway, with that, I'll turn the time over to Caleb, and thank him for being here.
Yeah, you bet. Thanks, Trevor, for the introduction. And I appreciate the opportunity to get to spend some time with you all here during your retreat. I know today is certainly a valuable time for you all. So as Trevor mentioned, Caleb Salter, I'm a senior workplace advisor with Gallup. I get the privilege of partnering very closely with our healthcare clients, in part supporting the strategy, the direction of those client partnerships, but then also co-lead here on our side, our internal team that is responsible for kind of the strategy of all of the work that we do that touches the healthcare sector. So ensuring that the research we're doing, the solutions we're delivering are directly aligned with the things that you all are talking about, and as a board of directors and as a leadership team for health systems. So as we kind of think about what I've put together here is kind of a variation of what we talked about with the leaders last week. So we'll kind of talk a little bit about some national trends across the workplace as a whole, but then also what are we seeing within the healthcare sector? And then we'll spend the bulk of our time taking a look at Star Valley's results in particular, take a look at the engagement survey results, take a look at that in a couple different ways. And then I'll close out with kind of the suggested next steps that I'd share with the leadership team that I know they're actively talking about in terms of what we're going to work on next. But without further ado, to kind of get us in here in our conversation, first slide that I wanted to kind of show you all here really is to help you understand the landscape across the organizations that Gallup partners with. So these are organizations that pay Gallup to measure the Q12 employee engagement survey. And so when we look at all of those client organizations, the average engagement across those organizations is 50% of those individuals are engaged at work. And really you think about those, and what engaged at work means is people show up to work every day and they're enthusiastic and they're highly involved in their work. They're individuals who are innovative, they have fewer safety risks than their peers, they are individuals who are much less likely to be absent or call in sick on the job. 40% of our client database falls into this not engaged bucket. I kind of think about these individuals as, they show up and they do what's expected of them, but they might not be going above and beyond exactly their call to duty within their role. And so they may be individuals who might be looking for other opportunities, but not quite as high as our actively disengaged populations, which is 10% of our client database. These individuals are the group that are certainly looking for new opportunities. They're usually the loudest people in the room. I don't think I shared this analogy with the group last week, but we kind of think about this group as cave dwellers. They're consistently against virtually everything. And so this really is the individuals who, they show up to work and they make everybody's life a little bit harder. They're the ones who probably don't get the highest patient safety ratings. The good thing is that when we look at Star Valley as an organization, engagement certainly is a strength. And especially when you take a look at it compared to our client database. This next slide here, wrong way. Next slide here is taking a look at kind of engagement, thriving, and burnout across leadership populations, managers, and individual contributors here. And why specifically I include this slide here is really to highlight the big gap that we are seeing within our macro workplace research around the difference in experience between leaders. These would be C-suite executives, vice presidents, compared to their team members that are more in that director, manager, supervisor population. There's a 10% gap in engagement between these two groups, which would indicate to us that there is a squeeze that's being felt on manager populations. It's a hard job to be a manager. And so that certainly is what is driving what we've seen as an overall downward trend across engagement from a macro workplace view. And then as we look at the healthcare industry as a whole here, engagement across the healthcare industry on average at 34%. I'll give you a little bit of a foreshadow to what's to come. Star Valley has much higher engagement than the average health system when we look at our polling. And so been trending upwards over the last about the last 18 months, which is good sign, good positive movement for the industry. But we haven't rebounded from where we were pre-COVID at 37% engaged. So certainly still some work to be done, some room for improvement. Some of you, this might be new, the concept of engagement. And so I thought I would just quick share with you how we measure engagement. What are the inputs? What are the items that make up engagement in our model? And so really how we got to these 12 questions was through thousands of different items written in different ways to really sort between high and low performing teams. Really wanted to know what are the most important psychological needs that an individual has that will help enable them to perform at their highest at work. And these 12 items stood out by far ahead of all of the other items from our research. And we continuously validate these questions, continuously look to see, are they correlating with patient outcomes? Are they correlating with safety? Are people showing up to work and having a better work-life well-being because of these questions? And our research time and time proves these are certainly leading indicators of organizational performance. And we'll take a look at kind of some organizational performance trends that we're seeing across culture of safety and turnover here in a little bit. Any questions thus far? Great. Okay. Well, next slide here is kind of a summary that we presented to your leaders last week. Basically kind of a summarization of kind of the three main chapters of the story and the analysis that we did on the results. And what we noticed within Star Valley's results is that engagement has improved since the previous survey measurement. Engagement overall is up 0.15, which would be near meaningful statistical significant improvement from one survey administration to the other. And we've got 9% more engaged team members today than we did during the last survey field period in 2024. So we've made a lot of really good progress across the organization. The data proves that no matter which way we cut the data, we see that everything is trending upwards across various groups and departments. We also know that engagement really is a local level initiative. And so it really is incumbent upon the managers at that local team level to be having the conversations with their team members, engaging their team members in the right ways. And we're certainly seeing that engagement is starting to sprout up at that team level. We're starting to see more local level ownership. We're starting to see results start to move at the local level, but we also still have some clear opportunities to engage some populations in the workplace that are key groups. And we'll talk about that here in a little bit. And then what we looked at here and this will be kind of like the closing couple slides for our time, is engagement a leading indicator for things like turnover and culture of safety for Star Valley Health? And it certainly is. And we'll take a look at how this shows up, particularly within culture of safety, and then taking a look at retention. This slide here is kind of our dashboard snapshot of the health of the organization, and I'll walk you through what we're seeing here. So this first upper left here, we're taking a look at the participation rate for the organization. Current was 72%, down about 3% from the last administration, but not a significant decline from a participation standpoint. And then 76% is the average across the healthcare industry. So pretty close to where the average organization is sitting from a participation standpoint. This year,
Caleb, when you say the word administration, you're not talking about former administrators. You're talking about the last time the survey was administered.
Yep, correct. Survey. So survey administration would be the last survey that was done in 2024. Good call out. So score is up 0.15. So for an organization of Star Valley's size, what we would consider to be statistical significant improvement from one survey to the other would be an increase of 0.2. So we got really close to what that statistical significant movement would look like. I will tell you, as someone who sits in these conversations with health systems, we're not seeing a lot of organizations climb by 0.15 today. I'm happy to see if organizations hold steady, maybe a little bit of some growth. So a 0.15 increase is certainly something that is worth celebrating. And there's certainly a lot of good positive news across the entirety of these survey results. And so when we take that 4.09 and we stack it up against all of the other health systems in our database that are 100, or that have at least 100 employees with less than 1,000, Star Valley Health ranks at the 66th percentile. So very strong benchmark performance there. And then compared to all of the clients in that segment, you're at the 67th percentile. So very strong benchmark performance. And like I mentioned, we've got 9% more engaged employees this year than we did in the previous survey. And we see that we've got 52% of our employees would be categorically engaged. If you remember, the industry average is about 34%. And across all of our clients, we're at about 50%. So Star Valley is certainly exceeding the median from both the industry and what we see across our clients. And then 40% not engaged and 8% actively disengaged. And that gets us to 6.5 to 1 engagement ratio, which is just simply that ratio of engaged to actively disengaged. And why this is important is I really think about this as this is how the human experience shows up at the hospital. When you walk past, 7 people, we'll just round up. For every 7 people you walk by, you're going to run into 1 actively disengaged employee. And so the higher this number is, the more that we're mitigating the potential disruption felt by that actively disengaged employee. And I've noted here on this slide, our threshold expectations for our clients is a 4 to 1 ratio. So Star Valley is well exceeding that threshold expectation, and certainly are moving in the direction of what we would consider to be a Gallup Exceptional Workplace Award or our top decile client organizations. Any questions on this slide? All good positive news, that's for sure. Great. Next slide here takes a look at the Q12 items. So this is looking at those 12 questions that I just talked about. This is how we measure engagement. And I've called out what I would say are our successes and our opportunities as an organization. And the thing that really stuck out to me right away when I started digging into the results is that there's a very clear, it's very clear that strong relationships are the competitive advantage for Star Valley. And I think that plays to the fact that you're a smaller community. You probably have people that maybe are, family members working for the same, or their friends, childhood friends, went to school together, maybe went off to college and came back to your community. And why I mention that is we see some of your highest rated items that have had some of the biggest increases from the first survey to this survey is the 5th question around someone at work cares about me as a person. My coworkers are committed to doing quality work, which should be the base expectation in healthcare, is that we're doing quality work. And then I've got a best friend at work. So those 3 items in particular all had positive movement. And when I see those items strongly positioned together, it usually indicates we've got very strong relationships, which I think certainly positions you all for great success. And we'll take a look at kind of that relationship component and how it shows up from a safety standpoint here in a little bit. Where I think we have some really big opportunity as an organization is to really hone in on the kinds of feedback conversations that we're having and the recognition that we're providing our team members and the progress discussions that we're having. And so you can see here, I've notated question 4, recognition in the last 7 days as certainly a significant opportunity. We've got a decent amount of people giving us a 1, 2, or a 3 here. And then as we take a look at progress conversations, we've still got a good opportunity here to engage in some meaningful feedback discussions. And, I think about in a nursing setting, this is really how we really target our rounding experiences to make them very high quality, where the touch points that we're having are not wasted one-on-ones, but they're opportunities that help our team members grow in their role in the day-to-day work. And so those are kind of the stories that stick out to me. I also picked on recognition and progress because those are the 2 items that when we took a look at turnover for Star Valley Health, when we just looked at the organization today compared to those that were a part of it in 2024, those were the 2 items that had the biggest difference in someone's engagement. And so you can certainly see that progress conversations are the way that we not only engage our employees, but we also start to retain more of our team members through those meaningful progress discussions. So there's more to engagement than just these Q12 questions themselves. And so what our team did is we looked at some of the additional questions that Star Valley has included in the survey. Things like, hey, I'm asked for input regarding changes that affect my work. I'm being fairly treated at work. And what we did is we did a driver analysis. And essentially a driver analysis here helps us to see, if we were to think about this as a puzzle, which of these items that are additional questions in the survey, which ones have the biggest piece of that puzzle? Which are the ones that could get us the biggest lift and engagement outside of those Q12 questions? And by far and away, the 2 items that make up over 50% of that puzzle are, I am asked for input regarding changes that affect my work, and I am treated fairly at work. So people are really asking for the ability to, be able to share their voice and to contribute to conversations around changes that are affecting their work, and they're looking to be treated fairly. So there's that equity and respect component coming into this conversation here. Any questions on the last 2 slides as we looked at some of the items? Great. Okay. Next slide here. Like I mentioned, local level engagement is key. What our research would tell us is that, beyond everything else, the number 1 variable in someone's engagement is their local team leader. And are they having the right kinds of conversations with their team? Are they action planning on their survey results? And so we took a look at the local team level, and what our research showed for us is those teams that participated in the first survey and also the second survey, 41% of them increased their team score by 0.2 or greater on their overall team mean. I don't see 41% quite often in healthcare. Usually it's kind of 30 to some degree. 52% maybe went up a little bit, down a little bit, but it didn't hit that statistical significant change. And then only 7% had a meaningful decrease in their results here. And so this tells us we've got 9 teams within our top quartile. So we've got 9 direct report teams at Star Valley Health that are in the top 75% of our client, or the top 25% of our team level database. So these are what we would consider to be world-class teams that exist within Star Valley Health. And I think this is a great way for us to say, hey, we've got some great recognition to do. We also have some great success stories to study and understand what is working with these groups, so we can lean into and use as some relative success stories for us as an organization. Next slide here is kind of taking a look at engagement as we cascade down the layers of the organization. So we're starting up here with the administrator group. So think about this as the executive group all the way down to our frontline employee group. I've called out 2 buckets here where I think as an organization we have groups that we can get some really meaningful lift, not only in those 2 populations, but that should also raise up the rest of the organization and have a heavy influence on our individual contributor group. And that's our provider group, whose overall engagement mean sits behind the median across their population, and our manager population, who sits just below the median within the manager population group. And so like I mentioned on the previous slide, this group here has the biggest influence on someone's engagement. And if you think about it, it's probably a hard job to engage your team if you're not engaged yourself. And so the real big story is here is how do we engage our managers and how do we make sure they are well supported to engage their teams in the right kinds of conversations. I also know from our conversation last week with your leaders that in some degrees we've got some providers who maybe not an official manager or a leader, but maybe they're a subject matter expert or a leader in the room with a group of other team members. And so if we can engage this group, we're going to elevate the patient care. We're going to elevate the experience of those that they're working with. So those would be the two groups. If I had to say focus here, these would be the two populations that I would recommend we hone in on and spend some time focusing in on. Last couple slides here, and then I'm happy to take any questions or thoughts that you all have. But one of the things that we did is we looked at the culture of safety questions that Sadie's team measured last fall, and to see of the people that participated in that survey, what were people that are engaged, not engaged, or actively disengaged scoring. And what we can see here is we can see of those employees that are engaged, they at a much higher rate scored the patient safety questions at a 4.04 overall index score, which is 0.53 points higher than those that are not engaged and much more higher than those that are actively disengaged. And so you can see here that there is a very heavy correlation between engaged employees and higher safety outcomes. And when we think about, if we look at the specific safety questions that were measured, where I think we really see our big success as a health system is these bottom two questions here, which are all about when lots of work needs to get done, we as a team work on this together. And when one area in this unit or work area gets busy, we help each other out. And this really goes right back to where I mentioned as a strength for you all as an organization is the relationships. And it's the trust and the respect that people have for each other, that they're going to do quality work and they're going to do what's expected of them on a regular basis. And then this last slide here takes a little bit of a look at turnover. So like I said, the two biggest differentiators between those that are with Star Valley as of this most recent survey and those that had left in between the window of the 2024 survey and this survey, the two biggest questions that had the biggest differences between these two groups and are the key differentiators are that recognition item, which had a 0.34 gap between the two groups, which would be a statistical significant difference in their experience, and progress at a 0.28 gap there. And then overall, we can see a 0.11 gap between those that are still with the organization as of the most recent survey and those that left in the window of time in between the first survey and the second survey. So this really here proves engagement is certainly a driver of turnover. We can see that people stay when they're more engaged. And we can also see here that when we have higher quality progress conversations, we're giving feedback on a regular basis, we're recognizing people, they choose to stay. And I think this is a pretty common trend that I'm seeing across the workplace as a whole, is people want to know, how am I progressing? What does my career path look like? What does development or that next step look like for me? And the last slide here before I kind of open it up for any thoughts or questions is just had shared some recommended next steps with the leadership team. I know we've talked a little bit about, maybe checking in a couple months with a pulse survey around, hey, how are people doing around their survey results and the action plans that are being put together, digging into that provider group and the manager population a little bit more to figure out what are their unique needs and how can we support them. So this is kind of some of the next steps that were shared, but I'm going to pause here and turn it over and see if there's any questions or thoughts that you all have.
Anybody? So Trevor, give us your synopsis of what you think about this from previous surveys we've had.
Well, I think the difference between this and the previous surveys that we've had is that we, like the patient safety, we've never been able to correlate because we've used different survey companies. Now we're using this for our safety as well, and it is cool to see the correlation there. It's also really neat to see the correlation of the people that stay with the organization and what it is that leads people to stay. So if we focused on two things, recognition and I think my opinions count, those type of things, I think that really kind of helps us narrow down where we need to put our focus. And so I think just overall, I was really happy to see that we had, the thought that helps me understand it best is if I'm walking down the hall and there's 7 people, I'm only passing 1 disengaged person, whereas before it was, 1 for every 5 people. And so that to me is meaningful and definitely feels like we're moving in the right direction. And we have some opportunities for improvement, but it's helpful to have this because we know where to really focus our efforts.
Any questions of Caleb or Trevor or anybody else in the room? Okay.
Is there, when he was talking about you have these high performing teams and that teams that aren't, are there teams that are on your radar as far as, we got some work to do and what might be causing the problem there?
Yeah, I think, specifically one group we've talked about is our managers and maybe, what is it about that job that is difficult and I think sometimes there's a little bit of conflict between, I guess, who they report to and kind of the staff and the expectations of the staff. They're kind of that go-between group. And so I think we can certainly work with our managers on development and helping them to navigate some of the challenges that they have. I also think we need to do a better job of getting input and feedback from our providers. I think just the way everything is set up, it doesn't always work well to be able to have that feedback. And I think it's just kind of just a challenge that we've known and had for a long time and trying to figure that out. I think we need to focus on those 2 areas. So. There's other teams that we saw massive improvement in, like just like if 0.2 is significant and meaningful, we had some teams that had 0.8, 0.9, so very meaningful improvement.
At the end of the day, culture and engagement, it's a journey, right? So this is our 2nd survey with Gallup. And I can tell you that there's a lot of great leaders in the organization that really care about their employees. And they're talking to them, they're concerned about them. And it does show quite a bit in their scores. Now, there are some managers and directors and even physicians that care about their employees, but the scores don't reflect that. And they take that very personal. Right? They internalize it quite a bit. So we have to be careful. In my experience of working with engagement surveys is, so some people went up and that validates that they're doing well. You're never done in relationships. You're always trying to nurture them. You're always trying to improve them. Relationships can take a step forward. They can take 2 steps back, right? And so when you look at our opportunity is we're heading in the right direction, but this is going to be a many-year journey. I want to give kudos to Dr. Cowan. Dr. Cowan, as chief of staff, he really, really cares about how providers feel. And his leadership is almost like a ministry of one-on-ones with various individuals, and so you can sense that that, when he and I talked a little bit about this, he hasn't seen the results on the providers yet. But you can sense that he wants to know, he wants to be able to say, okay, what can we do to make a difference? All these leaders on the admin team, their directors feel highly engaged, and the results show it. Where we're, now that we've got alignment with administration, department directors, the key is the managers. And Gallup sees that in the entire world, in all of their databases, is the manager position, and in our case, the providers. Those two, if we can somehow get a connection with and help them to not only just feel, but validate that they are that they are really part of the process and the improvement, and they feel good about their condition, it's going to take our organization to a whole nother level.
Of course, I know who providers are. Give me an example of a manager. Who's one of your managers? What are your managers like?
Well,
what is that?
Is there an example that you guys want to share? Go ahead, Tori.
I can just name managers in my department. So, as an example, the ED managers, Lindsay Hill, Ashley Hall is the med-surg manager, and Nicole Thompson is the OD manager, Mary Walker, care center manager.
Kyle would be a director.
Yeah.
I was saying above.
Yeah.
TJ Guild in the OR is the OR director. Becky Favors is the manager.
And so where's where's, I don't want to say dissatisfaction, but
why do you see that
driver
as
of
the
their
tier
lower
that
score?
needs-
Yeah.
So we had a great conversation as a management team when we reviewed the data with Caleb, who initially saw it. And the one thing that we landed on as a group is that managers feel pulled in a lot of different directions, right? So, and think of the providers as managers too. Okay, so every provider in our organization is a leader, is a director, is a manager, and is in the trenches with the employees. They are changing hats all of the time, and so managers they have to report to a director, but they also have to work closely with the physicians. And if there's any misalignment there, they may not feel like, well, I don't understand what's expected of me at work. I mean, they have a lot of masters, so to speak. And so we believe that is one of the main reasons why a manager might feel that squeeze. And Caleb, is that something that you're seeing in organization as to the why?
Yep. I would certainly say what we're seeing a lot of within our research and just some of the qualitative work that we're doing with manager populations is that managers are being pulled in several different directions. Managers are also having to kind of manage up and down. So they're having to manage the expectations and the requirements from their leaders above them, but then also the expectations of their team members. And so sometimes that means, hey, I've got to communicate something that maybe I wasn't a decision maker on, maybe I wasn't involved in this process, but now I've got to go and communicate that to my team and educate them on why we're doing this. And so you've got those variables that can make, being a mid-level manager a tough job that I think is really showing up a lot within the results we're seeing. But one thing we've been kind of doing with some of our clients is this activity of manager agency, really think about agency as what is within your span of control as a manager to influence. And so encouraging managers to come to a forum with new ideas, new thoughts, things that they can bring to the table to, better processes, better the organization, and be able to present those thoughts to the leadership team and get input and feedback on those and help them feel like, hey, we're a part of the decisions that are being made. We're being a part of kind of the innovation and the growth for us as a health system. So kind of that notion of agency of like what's within my control, I think is certainly a topic we've been exploring a lot within manager populations.
So, go ahead.
I was just going to say on the manager, specific to the managers, the questions that were lower were question number one, which is, I know what is expected of me at work. So I think that goes along with what's been said already. Question number three, at work, I have the opportunity to do what I do best every day. And I think sometimes the challenge is, you know, if they're focused on staffing and maybe covering a shift as needed, you know, sometimes they don't have that opportunity to do what they feel they can do the best. And then question number 7, and that is, at work, my opinion seems to count. So I think it all kind of, you know, maybe just a little bit of lack of clarity on what their role is and how to allow them to do what they do best.
Is this same Gallup poll administered to all organizations that participate in Gallup, or do you hand select the things you want answers to? Am I being clear on my question?
Caleb, do you want to speak to that?
The
Sure.
12
So-
questions, aren't they standardized?
So for the vast majority of the clients that we're working with, they measure the Q12 on a regular basis. So just like Star Valley has twice here over the last 2 years. But like Star Valley has done, kind of clients iterate around maybe some additional questions. What are some of the drivers of engagement? But for the most part, the Q12 is really the meat and potatoes of how we measure engagement.
Yeah, I just wanted to validate what I thought I remembered. Because if you hand select the questions you want to ask and you get your engagement based on that, you can't really compare facility to facility. I just wanted to know if it was asked. I want to ask a question and I'm not exactly sure if I'm going to word it right, but we'll just go for it. That's the Caleb. Can I ask it?
Yeah, please.
How do you account for people that, would you ever know if somebody was engaged? They weren't like the 1 in 7 that's disengaged, but they're dissatisfied with the job. And so then they just leave because they don't feel like they're being heard. Where could a person gather that kind of information from?
Yeah. So that's probably, I would probably put that group here. Let me try and navigate back to that slide. I would probably kind of put those in this not engaged bucket. Like they're probably showing up to work, but maybe they're a little dissatisfied, like you said, in their job, and maybe looking for other opportunities. What our research would tell us too is that 1 in 2 people, so 50% of the workplace, would say they're looking for actively seeking a new job opportunity. So there certainly is people looking, but it's not as quite a high a percentage of people taking new job opportunities. Maybe people are looking at that high of a rate, but they're not taking those job opportunities. So certainly I would say this is kind of that group that we kind of watch out for. But then as we think about from a team lens, this is where we can like actually get into the data. It's going to be these groups that are kind of towing the mid range here on this quartile team distribution, especially kind of the teams that are sitting within like that 40th to 60th percentile range, where we've got good scores. We've got teams that are, well in, they're decent engagement results, but they're not necessarily world-class results quite yet.
Is there a comment section on this Gallup?
We did not have an open-ended feedback item. But it's an option. Some clients do, some clients don't.
We didn't have an open up. Dr. Cowan, you had a hand?
Yeah, and I apologize. I don't understand what squeeze means.
The manager squeeze?
No, how does it relate to providers or feeling the squeeze? I don't know what that means.
You don't? Let me explain it to you. You have to be Montpelier at midnight and then writing poetry at 2. That's the squeeze.
I don't know. Yeah, can somebody explain that?
I didn't catch that one, so.
I didn't hear what he was referencing it.
Yeah. So
Are you
this
being
is
funny?
No.
He's being serious. I don't know.
He's asking a question.
Yeah, so probably more applies to the manager group than necessarily like the providers as a group. But I think some application to that group too. But when I think about kind of the squeeze, that's kind of what we've termed what we're seeing going on within manager populations, where they are kind of taking expectations from their leaders, taking expectations from their team, and they're feeling kind of that squeeze and pressure from both sides of that managing up and down within their line of sight. And so managers are feeling kind of that pressure from the two groups. I think about it for providers too, like that squeeze could be, hey, my voice isn't necessarily at the table like it needs to be. I'm feeling like some of the decisions that are being made are maybe not things that I've, been asked about that maybe impact my job. We know that one of the things that is a driver for providers is being in lockstep with leaders in terms of the decisions and the conversations that are happening that impact their work, that impact their department. So manager squeeze is kind of more of that's what we've been terming it as an organization from what we've seen within our data, is kind of that upward and downward pressure that's being felt on managers having to manage up, but then also down to their direct reports.
So they get squeezed from both sides? Is that kind of what you're?
Yep.
I guess?
Yep.
I feel like I can speak to this. I'm as a mid-level provider, like, I get why there's confusion, like physicians, they just get pressure, but I get what he's saying, because it's like, I'm an employee, let's say dental hygiene, and what's good for my patient and what's good for the bottom line, which is my dentist, who also does want what's good for the patient, but you have to reconcile, I didn't tell you you've got a $20,000 bill to be, and I know that it's not gonna be approached well, but if I meet all of their expectations and all the patient's expectations, I'm the one that's filling
Squeezed.
the squeeze. I'm not a manager. But I get the position. It's mid-level. I'm trying to think of Lindsay, she's got Kyle to report to. He relies on her for things, but then she maybe also does work around the nurses that she's telling what to do in New York. I don't know.
No, those are all the dynamics that exist.
Yeah.
And some people they can reconcile that squeeze pretty well. Others, they struggle. And sometimes we put people in manager positions or in those situations, and have we given them the right training and education to do that? So it's a question that we're asking ourselves about how we want to approach this data now going forward, so that we can better support the managers and the providers.
So, Dr. Kirk, first, you had a question or a comment?
I was just going to make a statement that there seemed to be a description for the managers as a two-dimensional squeeze of director versus the staff that they manage. And from a physician standpoint, I would say it's more of a spherical or three-dimensional squeeze sensation, where it's coming from multiple places at the same time, trying to please as many people as possible.
Okay. Trevor, you had another
I
comment?
was just gonna say, there is a lot of positives to look at when we look at specifically the provider engagement scores. They actually had meaningful improvement in 5 out of the 12 questions. The rest of the questions were, they wouldn't say it was meaningful, but they had 5 out of the 12 that went up a statistical significant amount.
Okay. So, Caleb, I have this. You may not even know the answer to this one. Have you heard of the Peter Principle?
I have not.
Dan?
I have.
So the Peter Principle, I read a book many years ago. My older brother gave me. Peter Principle is that kind of naturally people rise to their level of incompetence. And the reason that is because a lot of times people are really great scientists or research and development. So you promote them to a manager and they have no skills about managing, but they're really great, or maybe it's a nurse, really great at caregiving, but managing
People
are not. I mean, it's an art too. It's a different art than managing patients. And so I've always, and I see that a lot sometimes. I think we need to be careful in organizations that just because someone's successful, they may not want to move up and be a manager either. They may like being a nurse or a doctor, and like you say, doctors have a lot of hats on that. So I don't know. It's probably a new concept. There's an old book you can read.
Well, no, and I think you
get into that. I've forgotten who the author is.
You described it well, though. You think about not everybody's cut out to be a manager. Some people are great individual contributors and they're fantastic at their job, but maybe they don't have the ability to coach or to lead their team. And so that's where talent identification comes into play here. Is, are we promoting the right people into the manager role, and not necessarily just because they've had individual achievement and are great at doing that job, but maybe they're good at that job, but they also have high manager talent and high ability to coach and to lead their teams. That's some things that we do. I was actually just with the health system here in the office today, and we were talking about talent profiling. Do we have people in our organization do we have a bench of talent where we can spot who is a manager, who is somebody that could be on our radar as a future leader of the organization that maybe isn't quite in a manager or a director role? And do they have the talent to be in that role as we think about elevating the right people into the right positions?
What was your answer to that question? Do you have a Gallup test for that, or is it subtle?
We do.
It doesn't exist.
So we do. Yep. So that's probably the oldest work we've been doing, is all around talent prediction and fit for role. And so particularly, I would say our sweet spot as an organization is looking at managers and above and measuring talent and fit for those roles. And so certainly think about kind of the application there is not only who's a fit for the role, but then as from a succession perspective, who could be the next this director or the next this vice president that we can then pour in and invest in and give them the development and the experiences that they need to be ready to take that position when it comes available, down the line from retirement or, someone else getting promoted.
So the other side of that is that a lot of people feel like the only way to go up is into management. And so we need to be rewarding people that may not be the manager, so that they're feeling successful in, being the best nurse there ever was. And I think sometimes we lose sight of that. They only get elevated in remuneration or pay or whatever you want to call it because they went to a new position up to the organization, so to speak.
We're gonna take you to stay put.
Yeah, we're gonna reward you, and it may not just be pay. Yeah. It may be other things that they're looking for a reward. Anyway, so Tori.
I think it's also important to note that, and I would love other leaders to speak to this as well, and Caleb can answer the exact question to this, but we've heard from Gallup and other resources throughout the nation about the appropriate amount of individuals that should be reporting to one person. So I'm saying that because of what we've learned, we've increased our manager level location over the last couple of years. I'm sure you all are aware that. I know in my areas we didn't have managers before and we added them. So as those roles are new, we are training and learning together on how we can better support them, what their needs are, and this is helping us guide that and training them as we go because they are on the roles. But Caleb, what is that number, the direct report?
I would say across the board, it's about 9 is the ideal team size. Although for healthcare, there's obviously the caveat of the fact that nursing groups are going to have bigger spans. I can't remember off the top of my head what the typical nursing span is, but I can get back to you all on that.
No, 19 class size. School class size is what we're talking about here. There's only so many people you can take care of before it becomes dysfunctional or harder on everybody.
What I'll add though on span of control is that what our research tells us though is that a great manager, someone who has high talent fit to be a manager and has the skills to lead their team, they can make up for a certain degree of a certain size of a span. So it's not necessarily all about span, but if we're positioning the right leader to lead a larger team, so like for example, if you've got a floor of nurses and you're naturally gonna have a big span of control in that group, we've got to put the best possible leader in that situation because they're going to be able to maybe mitigate some of the effects of having a large span of control that naturally impacts someone's engagement. But it's a lot nicer when if you have a one-on-one on a regular basis with your manager. If you have, if you're on a team of 4 people, it's a lot nicer to, engage with your manager because it can happen a lot more frequently compared to a team of 50 or whatever.
Any other questions for Katie? We appreciate your time and giving us results. I assume we'll be another 18 months before we do the next one, or 12 months?
Well, we haven't really talked about it, but
Seems like we were on a plan to kind of do one every 18 months.
And that's what we did.
Great.
Great.
Okay,
Thanks, everybody.
Thanks.
Appreciate the time.
all right, let's jump back into Finance Committee report. I think is where we're at. And then we'll do the consent.
Okay, yeah, thank you, Mr. Chair. Just wanted to start off, I would definitely encourage everyone to read through the minutes and take a look at those. There's going to be a lot of things that end up in the minutes that I am not going to necessarily touch on in the report. I try to bring out some of the higher level stuff or some of the stuff that I feel like is important, but that, again, definitely am not covering everything in the report. Just kind of want to touch on as far as financials go for the month of January. We did see a little bit of deterioration in the cash position, which I'll touch on here in just a minute. We did see some improvement, and I'm going to call it improvement in our receivables from the standpoint that our receivables balances stayed roughly the same, but our allowance for doubtful accounts actually went down by about $500,000. And so it did improve as far as our net patient receivables. There is, right now, currently, we are working on an amendment, is what I'm going to call it. That's, correct me if I'm wrong here, Scott, to our cost report for 24-25, which should hopefully yield some cash coming back to us, which will help as far as that goes.
How far back can we go?
Just 24-25.
1 year?
2 years.
2 years.
2 years, 20.
Fiscal year
Yep.
24 and fiscal year 25.
Fiscal year.
And hopefully have it correct in 26, which we're in now, right?
So a couple things, kind of bouncing over as far as the income statement. It does show that we were a little bit, shows a small, or not small, but a net loss at the bottom. There was a number of true-ups that happened in the month of January that really affected the financials on the monthly financials for that month. And so it's hard to look at that as a January alone and say, hey, yeah, this is a true representation of what's happening. There's some true-ups within professional and purchase services, which is significantly higher, and some other true-ups throughout. Again, salary and wages tend to be running as the largest operating expense, but there's a number of things in there that had that were basically true-ups to effect that weren't a direct result of January.
So what do you mean by true up? Something that was false before, or?
We make our best guess to pay people certain things and then have to settle up once the contract's up.
Yeah, there's a number of estimations that are done or performed throughout as you're going, and as you get better information and as things progress, you have to adjust your numbers.
Which is just a comment. It's nice that it happens in January because our fiscal year ends July or June 30, and so for true-ups to happen there would be a disaster, right?
Right.
So has to come sometime.
Yeah, as I say, and I don't know. I don't know. We ought to say disaster per se in June 30.
It would be another hard thing.
I think you have to make it true up when you get the information to make that true up.
Yeah.
Justify it, absolutely. So with that being said, there was a number of things that impacted the financials there, but I kind of wanted to touch on specifically, there was a lot of discussion earlier in the year, and there's a plan that's been put in place by the admin team to basically reduce expenses. There's a strategic plan and improve our cash position. They have kind of a goal set in mind of getting to 50 days cash on hand. Days cash on hand did take a little bit of setback in January by the end of the month. If you broke down January, my understanding is first couple of weeks actually was, things were going really well and days cash on hand had declined, and then they had actually taken a setback, and primarily due to, if I understood right, through a change with Medicare, and the fact that they had to go through, Medicare had to go through a credential, where we did basically redo the credentialing, and the NPI numbers hadn't matched, and we had basically 10 provider numbers that were off, which caused there to be about $10 million in claims held up for the month of January.
Sam Linford was one of those, so obviously.
I just don't understand why the numbers would be off, like, he didn't change his number, it was just like
My understanding it was as a Medicare.
that's what I'm thinking.
Correct.
Yeah,
So we have to wait to submit the claims till the
NPI
NPIs
numbers.
are credentialed and they're matched from the hospital to the provider.
Yeah.
Versus just the clinic to the provider.
Mhm.
And it's just taking time to get them to process. And we processed about $750,000. It's through the system. There's about 1.5 million. We're just waiting on a daily basis. And we did some today, but for Medicare say, hey, it's good, push it through.
So how do the numbers get changed is my question, I guess, when I read that in the minutes. And maybe you know that. I mean, there were some that weren't correct, right? So were they never correct? And they must have been correct sometime.
Well,
Do you understand my question?
no, what number, the NPI number?
Yeah, the NPI number, I mean, I assume it was corrected sometime because they were sending us money.
Oh, yeah.
And then all of a sudden, 10 of them are out of whack. I guess how does that happen?
Well, in December, Medicare, in the past, they've always been, the provider's NPI has been matched up with the clinic NPI, the professional billing
Okay.
side of the house.
And that was good enough for Medicare.
Until December.
Oh, they changed
They changed.
the
Now they
rules.
want the NPI for the provider to be matched up with the hospital's NPI.
So now we gotta match them up with both.
Forbid that the government would ever change the rules. Okay.
And did our best to make sure that they all had them, but there was several of the positions that were missed. So
I
that,
understand.
it's hard to, it's, they have to go into the Medicare system and log in, they have to do a bunch of things online and getting that all happening and lined up so they can process their claims.
Right.
It's like I said,
So
unfortunately, one of them was Sam, which is a big, some large claims.
So the result of that, though, is that you see a increase in your receivables,
how that,
as far as the receivable days on hand,
Right.
and then a decrease in days cash on hand. So I mean, that's a trickle down effect.
But that should kind of work itself out though, right?
Absolutely. So one of the
Fix
things,
that.
and I asked Dan and Scott, I guess I should say the finance committee asked Dan and Scott if we could, or to update us monthly on this plan and how we're doing. I mean, the plan as a whole, but also each item as it comes up. And part of that is because I think it's a little unfair, maybe not a good representation to look at 1 month solely. Obviously we had a little bit of setback here as far as days cash on hand, but overall it should smooth out as we get this claims getting through. And so we're kind of looking more for a trend to kind of track that versus just a 1 month, one month. As far as, so we did get the final audit back. There was a number of things in there that were, I guess, mentioned, and Tanya has went through and remediated the controls, and that was suggested by the audit. A lot of it, the biggest focus was the internal controls and segregation responsibilities. I mentioned the cost report amendments, and we did discuss, Carrie was able to put together a report for us on capital expenditures. Essentially, they're looking at the capital expenditures on a case by case basis, being very vigilant and weighing the need versus the cash to perform the capital expenditure. And so they're having ongoing conversations as things come up in regards to the need of the cash situation. With that, I did want to address some questions. Came up here and some things that we've discussed, most of which we've discussed in the finance committee meeting. There was a payment to the town of Thane for the building purchase. It was the final payment, and that payment was missed. It was an oversight, an honest error, and there was a lack of understanding of the impact of missing that payment and the clawback clause. And so at this point in time, that note is paid off, but it did cost an additional $250,000 in back interest to the town of Thane.
How much was it?
$250,000. And so it's one of those things that it was missed, but again is now paid off and moving forward.
So when a question like that comes up, here's how I handle it. Back in October,
I didn't ask this question.
I know you didn't,
Okay.
but
But
you
yes.
did earlier, who should we talk to? So
Well,
when a
yeah.
question comes up, I happen to be reading, and I'll just give you my experience on the town of Thane. Back in October, I read the minutes of the town of Thane meeting. I know nobody else ever does that. I tend to do that every once in a while. And I called Scott and I said, hey, what's going on? Haven't heard anything about this. Town of Thane discussed it. And he explained to me that it was missed. And yes, it was that. As it became more and more of a discussion, I know Mindy had questions about it and that also. So I took it on myself to find out some more things. So I think there's multiple stories on everything. So I called the mayor. I happen to know him really well, and others in the hospital and our attorneys, and found out the background. And I think that's what a board member can do if you have a question. Now, obviously, you may not all feel like you can call the mayor of the town of Thane. I just happen to work with that community every once in a while, and so I happen to have a relationship. And I got some answers, and so I got to hear both sides of the stories. I read something in the minutes,
I did too.
December or
I
something.
basically put it in their report specifically.
Well, and the finance committee meeting, there was some discussion about whether it should have happened or whether things should have been as sticky as they were with that, and I thought about myself being in their position and a windfall. I don't know that I'm going to throw it away. So anyway, that's what I tend to do in these situations. I ask questions from administrators and others in the community that might be involved in the question. Just wanted to give you an example. Clint. Oh,
So,
okay.
well, no, so with you talking to Devin then, do you feel satisfied in his answer and?
Yeah. Yeah, I did. Yeah, he provided an opportunity for the hospital to come and talk to the council. And I think we made a choice at the time not to. And so it's just decisions. I also talked with Jeff England ahead of this meeting, and I know one of his comments, I think at the last meeting was, well, it's kind of small amount or something.
He's cost his business more than $250,000.
Yeah.
He's made more than $250,000 mistakes.
But I think what he was trying to say, and as I talked to him, he was explaining this to me, is that 250 in our organization is immaterial in an audit.
Yes. Yeah.
I don't think he was trying to say, I'm glad we made the mistake or anything. He'd like to have that money back and put it into good use. It was a mistake, but it's an immaterial to the $120 million. What's our revenues nowadays? 120 million, right? So anyway, and he wanted me to kind of clarify that with the board today because he's out of town. So
I'm glad to clarify that.
Yeah, he was in no way trivializing. Oh my God.
Correct.
Yeah, he just said, when it comes to an audit, that amount of money is.
Pretty insignificant in this organization. Now, if you were to come to my organization or maybe your organization, 250
I could retire
would
on
be
that.
somewhat of a material amount, right? So it's all relative. Okay. Did you have something
Well,
that?
I mean, we missed a payment. Okay, that's the information we get, because it comes multi-handed, okay? The iDaily report laid it out. It was actually months before the payment was made in October, when people were like $200,000. This isn't my report. I just read what I read, and I was like, that's what can feel sketchy. That they were well aware when when the mistake is made. It's a big mistake. Obviously, they think it's a big mistake, or they would have been like, oh, in a $120 million organization, it's not a big amount of money.
They mentioned it.
That it's like, it's February, and then you read it, and I read it for the exact details of it. It wasn't just like, we were a few days late on a lease. We owed the balloon payment. I can see because before I was like, I think the town of Thane was a little bit wrong in that situation. Then I read all the facts, and I'm like, how could they not? They had a contract. They need to execute the contract. It encompassed all of the back interest had it not been paid. And I get that we're talking about having a program to manage the leases, because there's so many, I get all of that. But when I look at the time that it was due, obviously we didn't have the money to pay it. That was when crap really hit the fan.
And it may have been it.
Yeah.
I think the question is, more than anything else, is do we have something in place so it doesn't happen again? I mean, to me, that's more the question on.
It's good. Yes.
When there's a problem like that, and I guess either you or Dan can answer that. I assume we have something now in place that says we're not gonna miss those things.
And Marlon, can I actually go to the next question?
Can you finish that?
Well, I think this addresses that a little bit as far as on the AP side. As far as addressing how we determine to pay our vendors. And
That's another question.
The next question, and I think that it goes along with this, correct me if I'm wrong, Scott, but basically, in the normal course of business, they're going to take advantage of any terms that they have as far as if they are net 30 days or whatnot. And so they pay all vendors typically in a 30-day time frame as far as the agreement goes. There are a few exceptions to my understanding, and those exceptions come from if there's a disagreement or discrepancy in what's billed versus what they're seeing that should be paid. And so they, under those, until they get that clarified, and then it's no payment at that time. And so, yeah, I think basically they're reviewing all the AP weekly to ensure that they're paying all the leases due each week. So with that being said, I think that review should help them keep the missing payment down.
So you feel comfortable we have something in place so that
Totally comfortable.
this wouldn't happen again?
Very well.
Obviously, one strike's okay, but three are not very good. So anyway, continue, Cole.
Okay. As far as the talking about Medicare, so we did address this in CMS and the adjustments. We did talk about this in Finance Committee meeting at length. The challenge is so yes, and I got this question outside of board meeting, but they're saying that the question was like, well, shouldn't we be accruing or allocating money for a potential CMS adjustment? And the answer to that is we were. But however, when we when it got down to the end and we were made aware that we were actually still short $1.6 million in addition to what was being allocated. So it wasn't that we weren't allocated for it, it was that we were off on the allocation that we were making.
Is that one of those true ups?
It's a big true up.
Yeah, if I may.
Is it really though?
Yeah.
A true up? Yeah.
Well, it's like you have your own personal tax return.
Yeah. I tried
That lady
to.
thinks, excuse me, when the tax return is filed, your estimated payments, during the year, you try to do your best.
Yeah.
In our case, Medicare determines our reimbursement rate. They tell us what they'll reimburse us based on the cost report we just filed and an interim rate review. The midpoint in the year last year, they increased our reimbursement rate significantly. Just doing their own reimbursement rate or mid-year review of our activity turned out to be too high. So they were paying us halfway through the year at a higher rate, and then they lowered it. And then you do the cost report and you say, oh, you know what? Should have made more estimated payments because we paid you too much, or we didn't withhold enough, if you were. So, we don't have deep, like tax skills. If you're a corporation, you have in-house, tax accountants and attorneys, etc. We don't have that, but we've learned a lot about the cost report and in the last month. And, there are some things we are going to do and have done that will allow us to know when we're being reimbursed at a higher rate than we should. But we can't. We wouldn't go to them and say, hey, you're reimbursing us too much. We couldn't never do that.
We'd say more back.
We'd just hold back a little bit more so that when they said, oh, you owe us some more, we'd have it.
And you don't return things to the government? Come on.
On the other hand, though, we would go and say, hey, we're being shorted. You would do that. And you'd prove it to them. And they
Depends on how you look at it, isn't it? I agree.
But it's just like that, the cost report is the answer, like the tax return.
And I think we spoke about this at the last board meeting fairly extensively. Dan went over the tools that they're putting into place, so.
That's what I was just gonna comment, is I think that at the end of the day, I think it's worth noting that there's been a struggle to correctly accrue for that in the past, and I think that's been addressed. They've had Ike Bailey come in and write for a week and do some training in January on a model that they have, and I know they touched on that previously, but there's been a lot of things that have been put into place and a lot better understanding of what goes into the cost report and things they can do to maybe capture some things that were either, being that weren't being allowed previously, some income that wasn't being allowed, and things like that to better.
Good. That's a great example, Scott, by the way. Estimated taxes. On April 15th, you'll all decide whether you were paying it up or not. You get a refund or not.
If we don't determine what it'd be like the IRS telling you what they're going to withhold, versus you telling them. And this way, they tell us too much. They said, we'll reimburse you at 62%, and then they dropped it down to 57%. But all the time that they're reimbursing it to 62% for outpatient work, it's too much. So we have, based on our cost report and where we're at today, we believe, they're still over reimbursing us, but not to the great extent that it was last year. It's like maybe 1%, like 57 versus 58%. So that could be, we accrued $200,000 in January. You'll see it on the balance sheet as a liability, potential liability for reimbursement. On the liability side there, it's a specific line. We've also accrued the benefit that we know we're going to have on the amendments. There's some other parts we don't know yet, but we accrued the benefit that will come back to us as a receivable. That's also on the balance sheet that you have in front of you. We've learned a lot. I mean, it's almost like the IRS code. I mean, it's so very, very complicated, but we're getting a handle on it, and we know the areas where we're going to dig down deep and find every dollar that can be reimbursed. Where it could be, we're digging down in and making sure that we can claim it on that amended return, and then in 2026 that'll be pretty good in terms of no surprises.
Right.
So,
Yes.
so just help me understand this whole body of Medicare reimbursement. So my reimbursement rates don't change all year. In fact, I'll make little adjustments for 2027 where they've adjusted little bits, but that's for so you're saying, like, just through the year randomly, they're like, oh, hey, BTW, we've just switched from 62% to 57%?
What's
they do is
BTW, by the way? Oh, by the way.
That's a good.
Old man.
You're probably reimbursed on a fee schedule, right?
Yeah.
We're not on a fee schedule. This is the total opposite of a fee schedule. We get reimbursed based on cost.
Yeah, I know that.
So our cost depends on how much utilization we have from Medicare patients. So that can go like this during the year. We have no control over how many Medicare patients walk in that door, into what departments and what procedures they have. So as you look at it's called a PSNR report, they can tell every claim that comes through Medicare and what we're actually doing. You know, and we know that, but they know they're just looking at Medicare claims and reimbursements and statistics, and they say, hey, looks like based on this, we're paying you too much or too little. There's where they adjust the rate, reimbursement rate during the year. It's one time during the year, so it's called the interim rate review. We're waiting for it any minute now, but then they'll say, give us this information, and they make an estimate to say, well, we're good there, or, you know, on part A, part B, swing bed, those are the three main areas, and they'll say, this one goes up, that goes down, this one stays the same. And then until the cost report, and then they'll do that, look at that again and say, that's another chance for them to up the reimbursement rate or reduce it in those three areas.
Golly. Okay. So how many times a year do you have to turn a cost report?
Once.
Okay. And then, this interim rate adjustment happens how?
Like
One
every 6
time.
months.
Well, approximately during the year.
Approximately.
So probably February or March is when.
Who initiates that? You?
No, I just get an email and go, okay, here we go, you know, and we provide them information. They have their information. They know what claims we filed. You know, all the revenue codes and then they look at our cost. We give them information regarding our cost, and they do their magic and tell us if we're on. If you know, they tell us what. It's crazy. It's hard to estimate. You can't guess. You try to do your best guessing because we can watch our utilization.
So is there
So do you
not
say-
like a generic equation that they have that? You said they work their magic, so they just put in the numbers and they do what they feel? Or is there not something out there that says, here's the equation you use, so we can watch it also?
Well, that's what we're trying to work with iBailey on, is we're trying to come up with a model that.
We'll have an adjustable model. So each year when they do the cost report, we'll take the cost report as quote a model that will apply to our future business in Medicare and say, using what we did last year, applying it to the utilization that's coming through every month, every day, you know, here's where we think we'll be. Plus or minus like a new doctor comes on or a new clinic we open or close or whatever. And, you know, we do these adjustments. And then the tool will help us to estimate whether at the end of the day, when the full cost report's done, we'll be right in there. We don't expect a return from the government and we don't expect to pay, you know, if you're a personal taxpayer. But it is a moving target, just depending on who walks in the door, if you're a Medicare patient and what type of work they're doing, the acuity of it, you know.
iBailey forces you to have so much in reserve for that variable though, right?
Is that?
Do we have to keep so much in reserve as a liability?
They're already doing
No,
that.
Yeah, you are doing that, I know that. You just come up with that number yourself.
Yeah,
Based on your best
because we
guess.
just,
But
Trying to get
Tanya and I
this
says, well,
tool will hopefully have a better guess, so that
yeah.
if they're
so-
paying us too much, we're putting it in the bank and getting interest, waiting for them to
So call it back.
call up.
Yeah,
So we
that's
actually
challenging.
could make money on that.
Most of the time, most hospitals like to be in this position because they've got a interest-free loan.
That's exactly what I'm thinking about it.
They have to pay it back, but you
You
know.
just gotta have the
we'd
money in
rather
your
have it
bank.
closer.
You gotta have the money in your bank to pay it back when it comes due. Kinda
So
like
again,
taxes.
we've learned a lot and I feel a lot better about our ability to predict. Tanya and I are just, you know, we know the questions and the things to ask ourselves. How we're going to account for things is a lot different. I'll just say this, and you can talk about this next month, but our Medicare mix is significantly changing the landscape of Starville Health. Just strategically, it's good. This model is different than what it's ever been. And so it's not necessarily a compliance issue now, but a strategy issue. How we, move forward into the future in this, we have much more Medicare, cost reimbursement. It could stabilize a lot of things, but it also can be challenging to manage.
So with that, Scott, either you or Dan, you guys want to clarify when we're talking about Medicare reimbursement, the percentage that we're actually getting reimbursed from them?
Yeah, and bring up to the board so like your physician's cost, what of that gets reimbursed, what does. I think it's just good for everybody, for Sean.
Yeah, we discussed this in the finance committee,
So-
I think it's important.
Well, we'll give you a little bit of a teaser, because we're going to be going into depth with the finance committee in March, which will then be a carryover to the board meeting at the end of March and part of our strategy discussion in the afternoon. This is without question, we feel the only way that we can manage this business going forward, and that is bifurcate the financials into commercial and Medicaid and anything else versus Medicare. And so once people understand that, all right, $20 million going towards physician salaries, it's not allowed as reimbursable cost under the Medicare cost report. You then start to ask yourself, okay, well, how you need physicians in order to generate the revenue from the commercial side, because the commercial side is covering a lot of the other things that we're trying to do for this community. And so as Medicare goes up in our percentage, and it has climbed.
This is chart for 47.
Yeah, do you have that right there?
Yeah.
I sent you a couple of little.
So what was it?
42.9.
It was 42.9 up to 47.
Yep.
Okay, so as that has increased, it's put more pressure on our margins on the commercial side to cover the Medicare, because we are not getting 100% of our costs. We throw around this idea of 99%. Well, it's not. It's 99% of 70% of our total cost. Everything else has to be covered on the commercial side. And so we have a very schizophrenic approach to managing this hospital, and that is, how do we maximize the reimbursement on the Medicare side, but at the same time create the margins on the commercial side, because the Medicare margins are negative 30%.
In the past, this hospital's been, we've been able to lever significantly the profits out of the commercial side of the business, enough to cover all the losses for, of Medicare business, which is significant now. And like Dan says, as that mix changes, our ability to lever, it's tightening down, it squeezes, it's compressed. And so we've got to balance it by, we don't want to spend more money because that decreases our profits on the commercial side. But we just got to make sure that every dollar that we can recapture from Medicare is back in our coffers to stabilize that part of the business. It's challenging.
So March is going to be a very important meeting, and I think that it'll be very enlightening as to exactly what we proposing to the board with our strategy. Our strategy going forward is somehow we've got to have a margin, and anything and everything that we do going forward. We've got some great investments that we put in place. We've got the Alpine project opened up. We have provided ourselves opportunity to capture more business, but we got to do this in such a way where we are maximizing the reimbursement of Medicare and at the same time capturing as much commercial as we possibly can. Strategy is have a margin.
So the one thing I'm missing here, I guess, is in your, and I saw it somewhere in the minutes where you talked about it. So we've always talked about it's supposed to be cost reimbursement, and it's only 99% rather than 100 or something like that. For many years, I've heard that.
Yep.
And then here, you're telling me, though, it's not really 99%.
It's not.
And so I'm not understanding why it isn't 90. I mean, it's
Okay. So
I'll show you.
It's allowable charges.
You had $100 million, let's just, of all our costs, right? And $20 million of those, those are all costs for all Medicare and everybody, right?
It's everybody's cost.
But $20 million, that's how Medicare starts. $20 million, that's not even allowed to be in the equation. So now you're down to 80 million.
Okay.
The salary position.
Okay,
Take
that's
that out.
reimbursable by Medicare to the extent that Medicare patients are applicable to those costs based on utilization. If we get 50% Medicare, then 50% of those costs, right?
Okay.
But then that's further reduced by certain costs are not reimbursable. Challenging little vernacular, so it kind of squeezes it down a little bit. For instance, freestanding clinics don't have reimbursable costs. They're reimbursed on a fee schedule. You have freestanding.
Bridge Valley.
Bridge Valley is one of
Bridge
them.
Valley, Evanston,
Freestanding.
and Diamond Valley.
Okay.
And so it kind of squeezes it down, and then you say, let's say, okay, they got, $40 million of Medicare reimbursable costs, 101% less 2% sequestration gets you to 99%. So you're down, you're just squeezing what you're being reimbursed on down further. And so when you take it all down there, you say, well, we really get reimbursed like, it's not 100%. It's 100% of this.
It's 100% of what they allow by definition, but not 100% of all costs.
Bingo. That's it. So it's really 99, when you take into account
99.
sequestration takes it to 99. It's 99% of what? Well, it's 99% of your allowed expenses on the cost report, which is not 100 million, it's actually 80 million.
It sounds like they're related to the IRS.
They all sit in Washington, I don't know. But the other thing is, let's say that we were, this is our case in 2025, we had $22 million that the program, Medicare, has for us on our outpatient business, right? Well, they paid us 15 million because, out of that 22 million, $7 million is copay and co-insurance. That's up to us to get it from the patients. And so they'll reimburse us up to, no, you got $22 million coming to you, but you got to take care of the 7 million from your patients. We'll give you the 15 million. So all those little nuances and challenges are part of the game of Medicare.
Thanks. No, I think I understand it better. Cool.
So this that we're talking about is that really highlights the importance of trying to better understand what is reimbursable and what we can allocate that direction, make sure that we're capturing everything that we can allocate, especially with the increasing.
Did I see a couple of things in my reading that they found a couple of things, at least right just off the bat, that we can be billing for that we haven't been?
Yes.
What did you guys have those as?
So
Not billing for, but cost that we can get reimbursed for, which we didn't know about.
Right. And you found out because of iBailey or?
Yep. So all the intensive 2-day training that we had with iBailey, with all our directors, managers, I mean, it was pretty dry. I mean, there were some clinical folks that were saying, please, somebody just put me out of my misery, right?
We were there.
But
That's when we had to stand up so we didn't get blood clots.
So, but at the end of the day, everybody in the organization walked away saying, okay, now we understand the game. We clearly understand the game.
So Abby, for example, correct me if I'm wrong, but like the emergency room doctor, he's got a little tag on that clocks where he's at, because when he's in with the patient, you don't get a charge for that. When he's doing extra work outside the patient room, then that's a reimbursement.
But it's only emergency room physicians. It's
Not everybody else.
Yeah, now,
That's all these goofy little things.
So now what we learned is, okay, so other physicians that are not emergency room physicians, if they're doing medical director work, okay, that's not patient related, we can actually, that's allowed. But we have to have it documented. It has to be, within the contract, it has to be fair market value. It can't be something. So there's now this conversation that's happening within the organization saying, okay, that we're going to have to look at how we structure things and do things so that we can maximize that reimbursement from Medicare.
And 50% of your business is now Medicare.
Yep.
That's right.
It's the idea that, like, for radiology, you would put a Medicare patient in the hospital on those terms, and you would move somebody that's private pay or commercial pay to a imaging center. Or not true?
No.
Not true?
No.
No, you want to stay here because they're
I mean,
helping pay the cost.
what I'm saying is people like me take care of the costs, go to.
Well, and that's just it, it's so.
I mean, I don't think you're not making that decision for your people, but people like me that have a co-insurance.
Yeah.
You're gonna make
Say,
a
okay, I
decision
get that you
elsewhere.
have to charge that amount because it's inside your facility, but I will happen to go where I can afford the
You don't
co-insurance.
realize that you're subsidizing all of us that are in Medicare.
I hear you.
That's what I've learned by becoming
And we're
a
having far
Medicare.
longer lives.
And we're having far longer lives.
No, it's, I've always told people that the young, healthy, employed, insured population is paying for healthcare in this country.
So I think I brought this up
What
in.
was that, the millennials, did you just say? Oh, Janet.
That's not me. I'm old.
So,
Remember?
so bouncing off of this then, and I think I've asked this in finance, okay, but do you guys have a set of, demographics that you can pull each year to give you an estimate that, hey, we can reasonably assume that Medicare is going to increase by 2%?
I think
in
we
27
can.
by 3%?
I think we can. I don't have like a, I think we're gonna have to put a couple of data points together in order to predict that, but that is something that we are talking about and how we can get that. You know, there's all sorts of population projections, right? Whether they're right or wrong, they try to predict, okay, this is gonna be your change in ages over the next 10 years. And assuming that the Medicare age stays the same at 65. But, you know, if that changes, then obviously it changes, we look at the population, but I think we can with putting some data points together.
Well, even just internally, surely there's a report in Epic that you can pull how many of our current patients are age 64, knowing well next year 65 when they come. Correct?
Yep.
That's the report.
So that would be a valuable thing to understand, right?
Yep. What we can't predict is how many of the 65 and older are dying.
In our valley,
There's actuaries
You're
for that.
disproportionately older.
There's actually, that's the data point we got.
I mean, if the national average is that well, we went to that meeting a year ago at the strategic planning, and I mean, the landscape was kind of scary. You know, we're getting older and staying alive longer for healthcare systems across the world.
another complicating factor really in this valley is that certain parts of our 65 and older population leave the valley for a portion of the year.
Yeah, who's
And
gonna
it's
say?
very clear as to the summertime bump, you know, where they come back and they have work done or they don't go away. Like this year, they didn't go away as much as they did last year because we had a milder winter. It has to be something like that because the
We need
rates.
to pray for snow.
That's right.
Mr. Chair.
Go ahead.
I'd like
Finish
to,
your report.
well, I'd like to circle this back to
Okay.
the question, and, you know, the question was, how did we miss? By as much as we did, and I think that, you know, from a 30,000-foot view, all this conversation that we had is all leading back to,
It's easy
as
to
you
miss.
make changes during the year, as you make changes to become more efficient, it actually dings you because now Medicare is going to come back and say, hey, you guys are more efficient. You guys owe us some money. And so as we made changes during the fiscal year last year, some of those changes come back and impacted us with our CMS adjustments. So I think it actually, my personal opinion, is that it actually increased the amount of our adjustments significantly by some of the moves we made to be more efficient in other areas.
It's just that horrible saying, the better you do, the worse you do.
No, but we want everybody in the staff to understand, we appreciate your efficiency as board. Even though we weren't accounting for it properly, we will in the future. At least I love efficiency.
Separating the finances, like private pay versus commercial, that's just to get an idea. That's just a glimpse in financial. It doesn't mean that we can improve our efficiency on the commercial side.
That's exactly right.
It does not mean that.
We can't ask physicians to say, oh, you're commercial, I'm gonna treat you one way. Oh, you're Medicare, I'm gonna treat you another way,
That
right?
really wasn't what I was saying.
Well, I mean, but you can see how that.
I mean, it goes to the point of why separate the financials if it doesn't make a business decision change.
It's only for a
That's my
business
actual
decision.
question.
It really is. It's just to make sure, that we as, you know, a governing body and as administrators, we understand how much of margin we're gonna have to make up on the Medicare side with the commercial. And if we're not making that margin up, we're gonna have to, the real decision.
We're gonna have to what? We can't treat you here.
Well,
So no care
well,
period.
then that is what
Versus
rural
treating
hospitals, that's what rural hospitals are having to figure out. So here we are trying to say, we've got an aging population. What services are necessary to take care of an aging population?
Mhm.
And if you do provide those services, can you sustain them? And if you can't sustain them, then what? So it's all about, when you come down to our mission, we want to provide access points that people can stay local for their care and sustain it.
Mhm.
Marla and I had this conversation. When you boil it down, that is what we're about. As a board, as a medical staff, as administrators, we have to fundamentally ask those questions and say, how are we going to do this? How are we going to pull it off? Because without the resources, can't do it. And every rural hospital in America is asking themselves the question, crap, how are we going to do this? So that is really the strategic discussion going forward, is what are the services? What's necessary? I truly believe, guys, having cardiology is probably a good service to have for a Medicare population. Okay? I truly believe that. I truly believe that neurology, rheumatology, there's certain things, primary care, internal medicine, oncology, all of these things we have to say to ourselves, okay, we've got these great services now. How do we sustain them, and do we add additional services? And if we do add those additional services, what does it mean as far as that sustainability question that we have to answer? So,
Oh, that's a good teaser. That's a good teaser.
Paul, you wanna finish up your discussion?
Sure. So just touching on, there's another question regarding capital expenditures and any potential delays or things that are scheduled and then delayed. Really, it comes back to weighing it between the need and days cash on hand. And if the need is yesterday, or is it something we can live along, or is it something that we need to have done? There's also some conversation regarding whether we pay cash for it or finance that. And I personally had asked Scott and Dan to take a serious look at, because the easy comment is, well, if it's a need, we just finance it. But at the same time, that you finance basically a remodel, or not necessarily a remodel, but a need equipment, or like a roof, for example, redoing that, you're basically just impacting your future cash flows. And so, and again, over time, and so we need to take a serious look about, we need to be careful not to just continue to leverage everything at that point. We need to take a serious look at whether we pay cash or finance some of that stuff. So, but yeah, as far as that goes, they do consider that they are working through the priority A CapEx and continuing down that road as cash allows.
Part of that question on cap was on capital expenditures, and maybe Mike even has an answer. So when we postpone something that was on our radar, are we going to we got to rebid it, or are we going to get those same folks back, or are they out of line, or are they ticked off at us? And is we change the timing on a project? And I realize why we're doing that. We're keeping our vendors happy, I guess, or are they just saying, I don't want to ever do business with us again? I was looking at Mike, but if you have an answer, Dan, go ahead.
No, let Mike has wisdom on this.
Mr. Chair, and Trevor may be able to add to this as well, but I think as you know, we did a prioritization on our capital budget for this current fiscal year. And if I remember correctly, we've already invested in just over $2 million.
After your budget, I think, wasn't
capital
it?
budget items that have already been done.
Mm-hmm.
There are a number of other things that we have determined we could wait for a period of time, maybe until the next fiscal year, or we've talked to staff and let them know that, hey, we're in a position where we can't really do that right now financially. And our staff has been very understanding of that. So I appreciate that from our staff members. The one thing I would tell you is we have kept in the loop of the communication, the contractors that we say the vendor for the roofing materials and the roofer. We have kept in touch with them, make sure the bid is still accurate. We've worked with the company that's planning to replace the hot water system at some point in time. Continue to work with them. They're a current vendor of ours anyway, that came in as a low bidder. Got a great relationship with them, so they're very willing to continue to wait until we're able to do it. Now, when it comes to, if you'll remember, our board has invested a lot of dollars in planning for a new building on this campus. And we even went so far as to select an architecture firm, paid for a bunch of architecture that those are some costs. We've got a general contractor, signed contract with the general contractor as well. I communicated with them earlier this week that, hey, we're still in a holding pattern financially. Don't forget about us. We'll give you plenty of time when we want to resurrect these projects and begin to pursue them again. And they're very good about saying, you just let us know. We're ready to help whenever we can. So
Great.
Just wanted to share that.
No, and I noticed in that CapEx chart that you handed out of finance committee, we really only spent money on priority A projects. I didn't see any in B or C.
I believe that's
These
correct.
are our higher priorities, and it's like, obviously we're getting, hopefully, all the things that you need in place. We're not becoming too thin in areas. I'm
It's
sure you're
really
looking at
given our staff an opportunity to decide what our needs and what our wants.
that.
And I really appreciate their willingness to do that.
Yeah.
And say, can't get along without that this year. I really need that now, kind of a thing. It's been really good to work through that. Made our staff more conscientious of the process.
Great. Anything else, Cole, on your report?
Yeah, so just moving on down through some of the questions here. It talks about, there was a question regarding the days cash on hand not improving. I think we answered that
You
previously.
just talked about it today, yeah.
The second part of that question though is we are paying Code Quick to capture these for us, as far as the question goes. Code Quick basically chases 90+ day stuff. I think Scott and his team is trying to move towards where the collection efforts, collecting things up front, things like that, will help mitigate the usage of, or minimize the usage of Code Quick.
Yeah, but they're on commission basis, right? So the more we pay them, the more we should have received. Is
But
that correct?
if we knew what to maybe capture in advance, we have less that they're already
Oh, yeah.
I mean, we had it 90 days earlier.
Right, but keep in mind that the more aged you get, typically the less
Less
you collect,
collectible.
right? So just because we're receiving.
So we're doing it at 90 or 180?
90+ is
90 plus is code change?
Quick
Quick.
Chase's non-Medicare commercial claims on insurance companies. They don't do anything in self-pay.
We don't throw them anything in Medicare, that's good.
We're actually, today, if I may, our over 90-day aged went under 10% of total AR for Medicare. So the rev cycle had a big party and bold today, they had to beat that. But that's the first time ever where the Medicare receivable has been less than 10% over 90 days.
Is that excluding the stuff that's held up because of the provider numbers, or
It's
that's
just total.
really across the board?
It's a very good milestone.
Mhm.
Really good milestone.
Great. Love to hear positive things. All
So
right.
just continuing on down, there's a question about the the letter, or basically the auditors were waiting to finish up the audit based on the letter from the bank. There was some back and forth there. Essentially, in those scenarios, banks have requirements they have to go through as far as approval processes, things like that. And Scott went back and forth with Mike and to get that letter, but it does take a little time to move back.
And just some background on that, when it was sent, the letter was sent for me to sign, and Abby, I think, attested or signed it also. I had some questions and called Mike. That was one of my questions. So why is this taking so long? And he just felt like it was a lot of things, a lot of little things that were kind of together. And so, yeah, now it's done. Now the audit's done, and hopefully we're more prepared next year for the audit to be a little quicker.
Well, and on that note, I do know that Scott and his team have requested the auditors to show up a month early.
Saw that in a minute.
So that's a positive move. And then I think the last question was on CapEx expenditures has been addressed already.
Any other questions any unanswered questions? Oh, there's one in the back. Dr. Cowan.
Clarification, and I hate
Please.
to, when we circle back, it sounds like everybody in this room has probably heard about this stain issue. I heard about it for the first time.
Okay.
I'm concerned about some of the comments. What was Jeff England's comment?
I think his comment in the last meeting was that, what kind of an insignificant amount?
Immaterial.
Immaterial. He didn't use the word immaterial, which is what I think he meant to use.
Oh, okay.
I think he used something like, I've made mistakes like that myself in his business.
Sure, I understand. I'm going to disagree completely with that.
Yeah.
And I tell a patient, oh, it happens all the time. Don't worry about it. It's okay. It's inconsequential, whatever word you want to use. That doesn't fly.
And he wasn't trying to say that. I think he was just trying to say the amount was an immaterial amount in the overall operation.
I agree with that too. It's a day's cash on hand, I would imagine, right?
And it may have been chosen for that, yes.
So I guess it was, I don't know, and correct me if I'm wrong, but my impression is it was rather flippant in here. Not a big deal, it's okay.
Oh, it's,
How is that okay? Somebody will have to explain that to me.
my view of it is it was a mistake. It was missed. And we need to move on. There's nothing we can really do to go back and change that, is my understanding.
Okay.
And so we can dwell on this for a lot of times. We can roll heads if we need to, but really what we need to do is learn from the mistake, in my opinion, have something in place so it doesn't happen again in the future, and move forward in life. I mean, life is, had a lot of conversations lately about, it's like flying a plane. You don't go in a straight line, you keep correcting. And that's kind of the way I see that.
Just what I heard was concern.
Okay, well, I don't know whether that answers it, and somebody else that may have a better answer, but that's my perspective.
Yeah, Mark, I don't want to give anybody the impression that we're being flippant about this. Similar to.
Well, that's my word.
Yeah, and so let's just make that on the public record is we have spent hours trying to understand how in the world did this happen.
Sure.
Right? So very similar to, a physician that has an issue and goes through a quality review. That same process happened on an accounting side. And the questions of, okay, track and trend, how do you avoid this happening again? It's something where everybody has had some input or involvement in this, they're like, crap. What happened? And those many hours of conversations have taken place internally. And the outcome is, one, is we have a totally different controller now in place. Two, is I would say that there really isn't any type of accounting or communication with who we were paying they don't have a business office in Dane. There's nobody there to tell us. I mean, because we didn't learn about this late payment until many months afterwards. Oh, by the way, there's this clause in the agreement which was put in place back in what was the year, Mike? 2013. You have different players. The only player that really who could potentially know about this one clause was Mike. We didn't inform him. So we've done a root cause analysis on it, and we don't in any way want to leave you with the impression that we're just being flippant about it.
Hang on. Follow-up questions or comments?
Well, some of this spurring this is within the last 6 months, I've heard a couple different times, and I'm sure it was said in jest, but in order to get out of this, we're just going to have to do more searches.
I haven't heard that one, but okay.
Well, I'm not the only one that's heard that.
Okay.
Okay. Well, I don't know that's certainly something we can do, but there's other things that can be done as well.
Absolutely.
So if you're going to spin it all back to the OR or whatever, I mean, I don't want that to be the thought process.
So,
I'm sure it was said in jest, but was it?
You might want to read back through the minutes of some of the finance committee meetings, because as they discuss that, we're looking at efficiencies. Do we lay off a lot of people? No.
Sure.
We want to look at attrition and where can we cut costs? And I think that's what I'm seeing the administration do, is looking at this probably in a whole different light. Yeah, it can't all come from new surgeries. There's another lever there, at least in my opinion, called expenses. And you can reduce those as much as possible. There's a point that you can't reduce a pass probably, and still be efficient. So I think that's also being looked at, Dr. Cowan.
Sure.
First I had Sean hand up, and then I'll come back to you, Cole.
How many contracts are there out there that have these weird clauses in? And is it not a bad idea to have one person doing these things every now and then? Because I feel like, and I could be wrong, but I feel like there's a building outline that the hospital lost because of another of these little weird things.
No, we knew that one. You want me on my opinion on that one too?
No, I want the truth.
Well, my opinion is close to the truth, I think.
Well,
so
the thing that I heard is that building Alpine was taken over by Alpine because they can for over 30 days. Like that.
I don't think that, I think, Mike, why don't you give us the truth?
It's just.
I
don't even know if I should be pulling that into it, but it seems like these little mistakes are starting to add up.
And that's a good point.
Is it not a good idea to maybe get one person to maybe review all these contracts? We're not like, oh, no big deal, we can leave the building for 3 months, and all of a sudden Alpine takes it.
Well, so we don't assume that the Alpine was a mistake. Let's answer that question first, because so Mike, why don't you just give a brief synopsis of that building?
Not sure that's brief.
Well, we're gonna have to try to make it brief.
Synopsis. So in '96, before the turn of the century, Star Valley Health worked with the town of Alpine to establish a clinic in the town of Alpine with Mayor Wooden at the time. Intermountain Healthcare gave us an old dilapidated building. The town of Alpine allowed us to place that building on their property. There was an agreement made that we would pay $150 a month for land lease. 95, that wasn't that cheap in 95 or 96. But that land lease stayed at $150 clear until 21 or 22. So when we built the new clinic across the river in Alpine, the agreement we had with the town of Alpine said that if the building stayed vacant, and no, not vacant, but if it were not used as a clinic for a period of 6 months, then that it would have to revert back to the building would revert back to the town of Alpine. That was in the agreement. So we talked it over with the town of Alpine. They felt like they wanted to renegotiate that, and they wanted $5,000 a month for land lease. We decided it wasn't worth it to us to do that. So we let them have the building back as part of that agreement. So we knew what was coming, they knew what was coming, and I feel like it turned out what it was. It really was part of the agreement.
So it was no loss because it was a pretty good.
Yes, we had remodeled it. We did have some investment there in the building, but we didn't feel like at the time we didn't have clinic services to put in the building because we were across the river in a new building. Did that help?
Yeah.
Trevor, you had a comment?
I was just gonna say, and as we were discussing this with the town, one of the questions that we asked is if we could potentially use that building instead of a clinic, if we could use it for housing our EMS employees. And there wasn't a desire to do that, and it honestly just kind of felt like, I felt, I guess, a little bit disappointed that we were not allowed to use that as an EMS housing location, because then we have to pay additional housing when we had the land available, or the building available to us, and we couldn't use it for that. Marlo even looked into.
And I believe the town is allowing it to be used as a clinic again, is that right? Or some private, there, I don't remember what's in there, but it's a medical, some type of a medical clinic. Is that your understanding?
The mayor also told us when we met with him that he wanted to use it as a daycare potentially for the town of Alpine.
I think the town of Alpine had other needs and uses, and it's just the way it worked out. What's that?
It was kind of a gotcha situation. You just didn't want 2 clinics in Alpine and Bergen was kind of that basically.
I don't know if it was a gotcha, it's just the police, the agreement.
$5,000.
Yeah, and what they wanted, so here's how I would view the two situations. One, the Alpine Clinic reverting back to the town, not a mistake, not a surprise, not a mistake. The lease in Thane and the payback of the interest, that was our mistake, and we have to own that. So that's how I would view this.
It was just kind of weird to hear that nobody agreed to contract since 2013. And it's going to happen. Go through a bunch of hands and stuff like that.
I think we had 2 of those types of contracts. One was the town of Afton, one was the town of Thane. We didn't have, Afton's turned out really pretty good. So
yes, back to the Alpine. The negotiation that we got from Alpine was give us $5,000 a month for a land lease, or buy the lot from us for $1.5 million. And we decided that wasn't a good thing to do. So we, in essence, we moved our possessions out of the building and turned it back over to the town. I think they had machinations of turning it into a new town hall, but then they realized there's no meeting room space in this building. It's all clinic exam rooms and offices. And they wound up leasing it to a couple of individuals. I think they're getting $1,000 a month for the rent now. What the original agreement was with the new renters. To the other point, we entered in 2013, we entered into 2, one with the town of Thane, one with the town of Afton. They were grants from the Wyoming Business Council that provided a portion of the funds to purchase what was then Jim Wheeler's therapy business. He owned those two buildings in Thane, and he owned this building where Fairview is here in Afton. The town sponsored the grant here in Afton, the town of Afton. The town of Thane sponsored the grant in Thane. We paid off the town of Afton several years ago, and they transferred the deeds to us without any problem at all. The town of Thane, we have notified them that now that we're square on payments and everything we owe to them, we are asking them to transfer the deeds to us. And we'll go through a public hearing process for them to approve that probably in April. And they'll transfer the deeds to us as the things.
Any other follow-up with that? I think Cole and then we'll come back to Clint. Didn't you have your hand up before I went to? I'm trying to remember 5 minutes ago.
Yeah, I did, wherever you want. I was actually.
Let's go.
I want to come back to Dr. Cowan's point, and I think that, you know, I am guilty of maybe going through that part of my presentation too quick as well. I think at this point in time, we need to recognize that it is, you know, every dollar is important, and I think that, you know, yeah, I could see where some of the comments, the fact that there wasn't more time spent on it, I could see where that comes across, maybe gives the wrong perception. And I think we are recognizing, and my take on it is, there's nothing I can go back and do to change it. And so, yeah, we're going to have to move forward. But honestly, I think the idea with this plan that we have, that Dan and Scott came to the Finance Committee with, is to get better across the board, because we have to get better. You know, we're seeing, if you look at the end of January, we're seeing 32 days cash on hand. I think it's important to recognize we have to get better. We have to be able to build days cash on hand internally, or organically, not rely on outside sources. We have paid off the short-term working capital note. There was a few other adjustments that came up that were a little bit of a surprise, maybe not a surprise, but things that had to be taken care of. They made those payments, got those things all squared up, CMS adjustment, everything, so that we could be moving forward. So 32 days of cash on hand, we should be moving upward from here on out, and that's part of the plan. That plan, and I asked them specifically to, you know, we don't want to rely on hope. There's a number of things that can come to pass that maybe be an influx of cash here or there, but we don't want to rely on hope. We've got to be able to have something in place that we can rely on, and these efficiencies. The plan is not something that is going to slash and burn something and gain cash overnight. It's a long-term plan to become more efficient overall. And I think that's important, that we recognize that we do need to be more efficient, which means that we need to monitor our expenses. We need to look for ways to better take advantage of the reimbursement, you know, especially on it. You know, we talked about Medicare and had a lot of discussion of that, but we have to be better about, you know, looking at how we can get more reimbursements for those items. It's all the above, and yes, it is great to have more surgeries, but we can't rely on one department to carry the organization by any means. So I think it's important, and to Dr. Cowan's point, I think it's well taken that, you know, it's all important right now. We do need to get more efficient across the board.
So I just want to speak to the defense of Jeff, to Dr. Cowan. He was posed the question, I believe, by maybe about the $275,000, and I know, I guess that's a lot of money, and to all us private individuals, that is. He just merely stated, to my recollection, that it wouldn't even rise to the level of materiality in an audit. So although he doesn't like to see it lost, it's not an amount that triggers a hair on fire reaction. Oh my gosh, we're in trouble. So he wasn't sweeping under the rug. I think he's just making a statement from an accounting point of view, numbers wise, if I understood it correctly.
And lastly, Mr. Chair, Mark, you know, I hope that you know that whoever you've heard that joke from, it's insensitive, it's sarcastic, but that is not our viewpoint. And I hope that it's not projected on some of the key decision makers in this organization, but that is how we feel about managing the situation. So, certainly, we know that everybody is trying to just do their very best in the situation. And, the other thing I'd point out as far as going forward is one of the internal controls is having a software that manages all leases. So this goes to, and the terms of each of those leases and how we can be, there can be a tickler that can raise, a certain issue. And so, mistake was made. We need to own it. We don't want to be flippant about it. I think that any joke about additional surgeries is inappropriate. And we put in place certain things to prevent it from happening again.
Good summary. Anything else, Cole? On your report?
No.
Any other questions for either Cole or the accounting department? Going once? Going twice? Okay, we'll move on.
Thanks, Cole.
Item D, under new business, ethics, compliance, there's a meeting on the 12th at 8 a.m.
Mr. Chair, are we going to approve the edit?
Oh, we need to do the consent agenda. Back to the consent agenda.
That's here.
Need a motion to approve the consent agenda, which is the financial results for the 7 months and the bills against the district.
I make a motion to approve the consent agenda.
Have a motion?
Second.
Cole seconds, so we have a motion by Clint, second by Cole to approve the consent agenda. All those, any discussion? All those in favor?
Aye.
Any opposed? Thank you, Andrew. So on item D, there's a meeting on the 12th. Go ahead.
I apologize. B1, the fiscal year 2025 audit results.
Oh, that was in your packet. We have a final audit with the forbearance letter from First Bank. I think that's all we needed to note on that. It's done. And I think Dan has something in your report, don't you, about that?
Did you vote to accept it?
I guess I read it in the minutes then.
It's in the minutes. Yeah.
Like a finance committee meeting, so. What's that?
Accept. In years past, you voted to accept. the audit.
Motion to accept the audit. Did we do this last month additionally?
No.
Did we choose not to? Thank you for reminding me. Okay,
So
so I need a motion. We have a motion by Abby to accept the final audit results.
I second.
And a second by Clint. Any discussion? All those in favor?
Aye.
Any opposed? I checked that off. Sorry. Thank you, Andrew. Okay, March the 12th is the next ethics, compliance, and technology meeting. Foundation report. They didn't meet? Okay, great. So nothing to report. Auxiliary report, there were minutes in your packet. Did someone attend? Did you attend, Adam? Would you like to add anything to the minutes?
they were just finalizing the details for the bingo night. I wanted to give a little bit of highlights from this. The Star Valley Health Auxiliary donated 2 CAD Solus VIP medication pumps to infusions of patients who can receive extended duration chemotherapy and food in their home, donated personal blood flow restriction equipment to the therapy clinic for physical therapy patients, contributed to construction of radiologist sleep room for the 48-hour shifts, provide scholarships each year for local high school students, fund 3 RV hookups on the premises for out-of-town patients and family members, maintain a gift shop for employees, visitors, and the community at large, host regular events to sell baby blankets, gifts to families who give birth to Star Valley Health, provide books to the Star Valley Health clinics to support the Raising Readers program, volunteer in the care center when health restrictions allow, volunteer in surgery center when health restrictions allow, participate in the teddy bear clinic to familiarize kindergartners and first graders with hospitals to reduce the stigma in hospitals, not being such a scary place. Volunteer at other hospital endeavors as the opportunities arise, such as foundation bowling tournaments, foundation golf tournaments, etc. Provided funds for the temporary helipad at the Alpine Emergency Campus and refill the water stations at the active physical therapy clinics. This was read at the bingo night, and I thought, since there wasn't much to report on the minutes themselves, I always say what an awesome thing the auxiliary is and what great they do. And I like this list because it puts into words the big things that I've noticed. And there were some on this list that I was like, I didn't even know those gals did this. So I appreciate them. And whoever goes to the March meeting can get the lowdown on the bingo night, which was very robust. They're a good name for the hospital. They're like the sweet spot at an airport.
Thanks. We'll get a bingo night report later. You're saying?
March,
Okay.
yeah.
All right.
Like with their totals, and I think it was successful. Yeah.
Chuck Cole.
Was it?
Oh, yeah.
I was out of town, so
You missed out.
I missed out.
How many seats there?
And live music, yeah, we'll let them
wow.
report on that later. It
We'll
was
wait-
really
we'll
great.
wait for next
Stadium's
month's
there.
report. Chief CEO report.
Yes, thank you, Mr. Chair. You have my report in writing, so let me just touch on some highlights. Going back to Abby's comment, the first thing we want to do is just recognize the care center. I think Tori said it best, and I want to just commend Tori, her leadership, as well as the rest of the individuals that oversee the care center. They're phenomenal in what they do for this community. It is one of our crown jewels. And here's what the two new auditors. So the care center has to be surveyed once per year. The hospital is every 3 years, and so they're always on alert for these surveys. And the two new auditors had never been to Star Valley Health. At the X interview, they had our findings written on a tiny scrap of paper and mentioned that they had already picked out which room they want when they return to get care in the future. And I think just that statement alone speaks volumes to the quality. And I listed out the infractions that they listed, but we're obviously have a plan of correction.
Already corrected.
And submitted, and so there's so much good about the team and how each of us have aging parents, and how we treat the elderly says a lot about the character of who we are. And I every time that I interact with Tori and the leadership and the good people in the care center, their character is pretty solid, and we should feel very proud about our care center. So, with that being said, wanted to make sure under loyal patients, what I did not include is, and this is very recent, is we have confirmation that the week of March the 9th, our billing survey will go live. So we have very specific questions concerning billing experience that we're going to be able to have objective data to then make some decisions. A big kudos to Mike Hunsaker and Chris Hinton. They've been spearheading a lot of this initiative, and without their efforts, we wouldn't be able to have this in place. So we've moved very quickly once we have engaged a survey Qualtrics, and the partnership so far is going very, very well. And we're actually just as an FYI, you're going to see all of our surveys move over to Qualtrics because of their ability to give us insightful information about how to improve the overall experience for our patients.
Including our Gallup?
The Gallup will stay with they'll be the employees. Yeah, but anything touching the patient.
Okay.
Yeah. Also wanted to just thank Tori, Dr. Kirk, Dr. Cowan, and anybody else that was involved with Telenocturnus and the Telefeeds program. Again, a lot of coordination to make that happen, and a lot of credentialing. Kudos goes to Deirdre. All these teleservices, Deirdre is just constantly working. So when you see Deirdre, make sure that you tell her how much the organization appreciates her. And it'll go a long way because she's a one-man band, one-woman band in getting all this done, and she does a phenomenal job in making that happen. Teleneurology, we're still looking for next month to bring that on, and then interventional radiology, we've moved to May. That's when our interventional radiologists are going to be on site to start seeing patients. The other thing, you can read through much of what we've already talked about. I wanted to make sure that the board had some time to understand. Tomorrow morning, we're meeting again with all of the players involved with the EMS district. And I've asked Mike to give the board an update on what the timeline looks like from now until November, so that you're aware of where, there was an article written in the paper today about the EMS district, public hearing, and I've asked Mike to just give you a glimpse of what we're going to be talking about tomorrow, so that you're not completely in the dark. Go ahead, Mike.
Okay. Got up on the screen here for everybody to view. Just for your information, as you know, we've had an EMS working group has met for several months now. Tomorrow morning is an additional EMS working group meeting. That means we've invited all of the towns, Alpine, Star Valley Ranch, Spain, Town of Afton, the county, Commissioner Shumway has attended very regularly. Senator Dockstead normally attends, but I think he's kind of busy right now. We probably won't see him tomorrow, but we'll meet again tomorrow and further our discussion on EMS district. So just for the board's information, the timeline that we'll be looking at is on March 17th. The county commissioners have agreed to hold a public hearing, and that's being advertised right now in their regular commission meeting in Kemmer, which will be live streamed to the Afton County building as well for those who want to attend the public hearing. After the public hearing, the commissioners will close that hearing, and they'll allow us, by statute, they have to allow 60 days to elapse before they would hold a vote as to whether or not they would create a district for EMS services. Our proposal to the county commissioners a few weeks ago when we went to see them was that we asked them to consider the same boundaries as the North Lincoln County Hospital District. That's been taken through its paces. The county clerk and the county treasurer have looked that over. They submitted that information to the State Department of Revenue. The state requires the state to look at that to make sure there aren't any overlapping districts. And since there aren't any other EMS districts in North Lincoln County, that passed through the Department of Revenue without any problems. So after the 60 days time of public comment, the commissioners on May 19th, so the 60 days will end on May 17th. On May 19th, in the regular commission meeting, the commissioners would hold a vote to either create or not create an EMS district in North Lincoln County.
That's a vote by who? The commissioners
That's a vote
themselves?
by the commissioners. The three commissioners will vote on that, right? If it's a yes vote to create the district, the commissioners would then appoint 5 board members to serve as newly elected board members, not elected, newly appointed board members for the EMS Special Tax District. They would then, the commission would they're actually, forgive me, County Administrator Allen, as I discussed this with him, he has suggested that the EMS working group that's going to meet tomorrow provide the commissioners with 5 names of people who would be willing to serve on this EMS district board. And as I have circulated that information around to the various stakeholders, everyone feels like we should have a person who lives within each of the boundaries of the 4 towns in the district, and then someone from within the county in the district boundaries. So that'd be somebody from Alpine, Star Valley Ranch, Thane, Afton, and somebody from the county.
That works out nicely, doesn't it?
Yes, it really does. And I think that the commissioners would be very appreciative of us, of the group, the EMS working group, to provide them some names of people who would be interested in serving.
Hey, Mike, just a super short kind of, my operational understanding was you're going to try to get South Lincoln, make it a whole big district. That obviously is not a.
Yeah, it was initial thought, and we've had conversations. South Lincoln said, we're not going to get involved. We're going to take a wait and see approach.
Thank you.
So once the new board is formed and appointed by the county commissioners, the board would begin to do regular board work, which would be appoint officers and start to do EMS district board business. And I think the first thing on their agenda would be to determine whether or not they ask for a mill levy and how large that mill levy would be. They are able to request, as a new board appointed by the commissioners, they would be able to request and have put on the ballot up to a 4 mill levy, requesting approval from the voters. And that 4 mill levy, or whatever the levy is they ask for, would be a perpetual mill levy that would be assessed every year until the commissioners determine to dissolve the district. So they could ask for up to 4 mills.
I thought there was a minimum of 4.
We've gone round and round and round about that, and the county attorney and Mr. Taylor have decided you can ask for 4 mills and it stays in perpetual.
Okay.
The perpetual is it could be removed if 10% of the voters within the district brought a petition to remove it, then it could be removed, but otherwise it would be in perpetuity. The 2 and the 4 distinction is the method in which you create the special improvement district. So the 2 is if you were to use a petition to form,
Okay.
but under the method that we would be using, which is just a straight creation from the Board of County Commissioners as is described, it could be a straight up to 4.
Okay.
So then at that point in time, the new EMS board would notify the Lincoln County clerk, April Brunsky, of their intent to be on the general election ballot. They have to let her know that before July 15th, 2026, so that it can be on the November 3rd general election ballot. That's in essence the timeline to get to that point of getting on the ballot for potentially an additional mill levy from the voters to fund EMS.
So the meeting for the commissioners to decide was May 19th?
Yes, that would be their final decision on whether or not to create the district.
And they need to get the board has to get formulated in 60 days and figure out a budget and ask for 4 mills.
Yes. So there's
Who do they ask? The commissioners or just go right to?
They would submit that to the, I'm sure they'd have to submit it to the county commissioners, but it has to go to the county clerk for her to get it on the ballot.
I assume there's some approval maybe by the commissioners.
No, I have not heard that. Is there, Brandon?
It has to be given to the commissioners. The language is a little ambiguous as to whether they have an option, right? It reads to me that it says if the EMS board votes to put it to the ballot, I think it's like an accept language that the board of commissioners would accept that and relay it to the clerk. So I suppose, if they
politically, you're going to do that anyway, aren't you?
But so it does go to the commissioners, and in theory, they should just pass it on.
Okay.
I would mention to the board that we have made, we've been to the town of Star Valley Ranch. Then Mr. Ordina attended that meeting and gave them a presentation regarding our our efforts in this area. I was able to attend the Town of Afton's council meeting and made the same presentation to them. Last week, the Star Valley Ranch Association asked us to attend their meeting, and I was able to go there and give them the presentation, and I think Star Valley Ranch was very receptive.
The association?
Yes,
Okay.
they were, and I think Dad would say the town was as well.
I got an ovation, he got a standing ovation.
Yeah, but they're two different entities, and the one that would matter would be the town, right?
But it's the same citizens.
It is the same citizens. It's just completely wackadoo that it's two separate entities. So let's just not go there.
Strike that from the record.
No, it's absolutely crazy that it's not a recreation district. On note, I want noted.
The only reason they stood for me was they had to put the chairs away.
Don't move.
But the discussion was very positive. I was involved in at the Ranch Association. They understand the need to have ambulance service. They really understand that need.
Well, that's our Medicare population.
That's exactly right.
They're like, oh, right there, one city for us.
And guess who the biggest users of EMS are?
Yeah.
That's Medicare.
65 and older.
We intend to get to the town of Thane and to the town of Alpine here in the next, probably over the next 30 days to try and visit with their councils. We did make a request from the town of Star Valley Ranch and the town of Afton to provide a letter of support to the commissioners that they are supportive of the creation of an EMS district. Not for a new mill levy, but for supportive of the creation of an EMS district. Town of Afton felt like they were willing to do that. Dan, you may want to comment on Star Valley Ranch. We'll see what the town of Thane and the town of Alpine, how they feel about it. I would say that Commissioner Shumway did a really nice job in his radio interview the other day, and most of that interview is in today's newspaper. He was spot on all of his comments about the process, and I think our commissioners are pretty supportive of the creation of the district.
Creation of the district, yes.
Got to be really careful about that. Yeah.
Well, and Mr. Chair, I like Mike's distinction. You know, he and I have had numerous conversations about this, and the question about how somebody feels about property taxes is not the question we're trying to answer right now. Right, that's in November. And so we want to separate this, you know, how people feel about property taxes from how they feel about an EMS district. And all we're trying to do is say, hey, is it worth it to form an EMS district and then go to the voters for them to decide personally whether or not I want to attach because I truly believe that there are some people that say no property taxes, and there are some people that will say property taxes are good if I know that there's a local value that I'm getting from those property taxes. But every individual on that spectrum is going to be different.
So, Mr. Chair.
Yes.
Can I ask a question? So we're talking about an EMS district, and I'm just, and I know we're separating the property tax from the district right now, the creation of the district. But where do we go once the district is created? Where's that going? The reason why I'm asking is, we're talking about up to potentially a 4 mill levy number, which, correct me if I'm wrong, but our property taxes this year are expected to be around 1.3 million.
That's at a 3 mil, though. You gotta add another.
Yeah, he's doing that.
I was thinking we were at 6 mil.
We're at 3. We're 3 at the hospital district.
Okay.
So we're at 1.2 this year.
1.3, but we could go up to 6, but we never have.
Go up to, but we never have.
So your 4 is gonna be under 2.
So, okay. So you're, let's say, 3 at 1.3, so you're 1.7, let's say. And we know from experience of operating it that just payroll alone has been in excess of $3 million, right? So where I'm going with this is there's still a huge gap It's gotta be covered somewhere. Have we had conversations? Have we approached that?
Yeah, so in the work group that we've had, this will be our 4th meeting with the work group, we have put together a financial statement of all the direct expenses. And the most recent analysis through January or December?
That's through December.
December of 2025, is that when you take into account how much we're billing and collecting, minus all the expenses, the deficit on the direct, so there's still some HR accounting that are not part of this number, but it's a $1.5 million loss.
That's actually better than I thought it was. So,
And we figure you're gonna just kind of fix that in every year.
I got a neighbor, Surveyor Sherman.
Is that where you live? Up by here?
No, I'm talking, I got a neighbor that's on Surveyor Sherman.
It's challenging because I asked, is
I'll
this
ask
gonna
him
be
for
separate
donation.
from the hospital? And it is intended to be separate from the hospital, but you guys are doing all of the education for it, and like the Misty's List crowd has already had their 2 cents. You probably saw that.
Yeah.
No,
Well, the gist of it being, they think that the $1.2 million mill levy that already comes to the hospital should cover, and why, why would you pay the taxes and then also have an emergency, an ambulance bill on top of that? There's a lot of information that we need to, a lot of education, and there's just not enough time. But it's nice you're educating.
well, but a lot of that information comes later after forming the district. If there's no district,
Yeah,
then we
totally
don't
get it.
have, that's a
Why
moot, that's a
is it
moot
out?
question.
I get it.
Once we get the district formed, which is why it's kind of separated,
Mhm.
then there's a question, what are our sources of funds?
Yeah.
And is it just mill levy, or is it, I mean, there's gonna be other sources of funds. but-
Grants, rural health
Grants.
transformation, you know.
Mr.
Sean
Chair,
first. Sean had his hand up before you did.
I had a second part.
Oh, go ahead.
Yeah, it's all good, go
Follow up
ahead.
with your question then. Go ahead.
Is it an option to separate, when it creates a separate district, does it create a weird separating EMS from the hospital? Or does it have to stay in the hospital? Because I think we talked about it last time, like pretty much every bit of money that comes in from property, we're not talking property taxes, but every bit of the money that comes in goes back out to EMS.
Correct.
Right now. And we talked about almost creating a separate account that one time we need to like, let the people, that's what's at, it's all just going. Is it, does this make it easier to separate EMS from the hospital? Or is it always gonna stay in the hospital and we're just gonna?
There's debate about that. And I think at the end of the day, the EMS district has to be completely transparent with the public, right? Because they're public funds. And what the relationship is with the EMS district and the hospital going forward, that's yet to be determined. And I don't think that the EMS district can completely be successful without some involvement, you know, from the hospital.
Just to reiterate, our unification of the EMS allows us to bill more effectively.
Yeah, so there is.
Like if we're competing within 50 miles or something,
Yeah, there
that's a challenge.
is better reimbursement under our contracts without question. So we recognize that just by creating an EMS district and getting additional funding, I don't think it solves all of the questions or the problems. I think that the new board would figure that out really quickly. And so we're making sure that why the EMS district is really the only option is everybody's looking for funding sources, right? Of how to support this. And we know that our hospital doesn't just pay for EMS. You know, there's other subsidies that we're providing in the healthcare area that you know, we've got to figure out sustainability pathways forward. So trying to figure out EMS sustainability, EMS district seems like the collective way forward. But I don't want to sit here and pretend like, hey, this is just going to work out perfectly. It's still going to be a challenge without question on how to make this transition. So you used the word weird. Yeah, I think it's gonna be a little bit weird. Okay.
I didn't forget you.
No, you're good. So I think I just wanted to make the point that and I hope that in these meetings that, and maybe this is just my personal opinion, but where I was going with the financial obligations still out there, not gonna be covered by any type of levy or anything like that. I'm hoping, and to your point, the hospital, it makes sense to be involved to some extent. But at some level, these other stakeholders have to come to the table. I mean, in order for this to be successful, it can't just be the hospital. And I'm hoping that these other stakeholders are realizing that, and at the end of the day, for it to be successful, it's going to take more than a letter of support for the district to make it successful. So,
Yeah, I think people realize that there's no good answer to this, and there hasn't been a good answer for anybody in Wyoming. In fact, if this happens, this would be the first EMS district in the state of Wyoming. I mean, we'd be pioneering a community kind of just tackling this issue head on. So it's, like I said, guys, this could be an abysmal failure on my part of trying to bring all these parties together and trying to make this work, but what are my options? I gotta try.
See what happens, Mike?
Mr. Chair, I wanted to address Abby's comment regarding property taxes and whether or not I have to pay for an ambulance, right? Here's a really great analogy for board members to use when you get that question on the table. It's like your power bill. If you don't flip your light switch on, you still pay a base rate for your meter base. Property tax. You flip your light switch on, you pay a power bill on top of the base rate. So that's a really good way to explain that. And I use that very analogy with Star Valley Ranch, and you're like, oh, okay, I see what you're saying. Because that was brought up to me at the Ranch Association. Well, if I'm going to pay extra property taxes, why would I pay an ambulance bill? This is why.
Well, another parallel analogy is, okay, you pay property taxes to the hospital district, therefore you don't have to pay any hospital fees.
Right.
You know?
Yeah, I definitely don't engage on Missy's list, so I definitely wouldn't use it. It's a great analogy, won't be using it. But I'm the exact example of somebody who hates property taxes, but I mean, I voted for the Mid-Valley Fire District. It made sense. We're growing and it benefits us all to have more resources. Same with the ambulance. It's like, I might not need the ambulance. I might be able to drive myself in, but like every second that I'm out and about in my car or my children are out in the world is the potential that we do need the services. So
that's the base rate.
It's not like paying for a swimming pool or a golf course. It is a universal service.
You calculated what the 4 mills would be to a local resident?
So if on a $500,000 value, well, somebody did this math. Can
I did.
Yeah, what was it?
1.7
I think it's like, I have to do
Or
it
you
again.
did the
$100?
Oh, what each citizen, you're paying $100.
So if your value, assuming
you're paying to have the quantity of equipment potentially available.
$200.
It's $200 for 500,000 for 4 mills.
I think so. Did I do my math right?
I didn't want to be snarky, but
that
I mean, the
right?
fact is half of the calls at the
You
ambulances
take
go on.
500,000 times 9.5%, gives you assessed value, and then multiply that by 4 mills, which is 0.004, correct? A tenth of a penny is a mill.
Pennies don't exist, so that has to change.
Pennies do exist, just not in the government's mind anymore. I still have some.
Me too. They're collector's items now.
Collectors.
My kids have been going around the house collecting pennies, and they're
Are
telling me
they
that
worth more or less than a penny?
they cost more than a penny to make, so they had to cut it out.
Anyway, so yeah, it's like $200 a year premium to have the ambulance show up if you need it. So
I pay for a
At
lot
the
of,
forum.
I pay for a lot of things that I don't care to pay for, that one's not really one of the ones that I find.
So
I just hope the message articulates.
So,
all.
so the last, so I think it's gonna be important is we're gonna need to make sure that the board is unified on, maybe not the idea of property taxes, but the idea of creation of the EMS district. You know, Marlo as the chair, I think we gotta be careful. Because, you know, there's individual opinions about this, right, as board members. But what is the collective? What's the collective sentiment of our board as we go out into the community? Are you in favor of it? Or are you against it?
So should we have that discussion next month
Well,
and maybe get a consensus
yeah,
before the commissioners meeting?
no, we already have the commissioners meeting on March 17th.
No.
So
Well, as part of our strategic, we may need to have it.
He's asking for it right now.
Are you wanting it right now?
I'm just bringing it up, Mr. Chair, that I think it's wise to make sure that there is some unified message from this board about it. So
I think we put it on next month's agenda. We're missing 2 people, and I'd like to have them involved, and I think everybody will be at our meeting on the 25th of March, because it's pre-planned as a strategic meeting. That's my suggestion, is we have a small discussion and get a consensus. Yes, it'll be after the commissioners meeting, but not after the 60-day comment period or the
so we could
vote on May 19th.
We could send that in via writing, right?
Yeah. Okay, anything else on these topics? FYI, we have a planning meeting on the 25th, starts at 8 a.m. in Thane, on Main Street. There's also you want to speak to this, Dan?
Sure.
May the 19th, that's the day the commissioners are voting.
May 19th, huh?
Popular date.
So the Wyoming Hospital Association has a board training in Sheridan. And I would like to invite every single board member to attend that. We would fly you to Sheridan. I think it's on a Thursday.
Tuesday.
Was it Tuesday? So we'd have to fly you on a Monday. And then you would attend the meeting on Tuesday, we'd fly you back on that Tuesday. There's no issues. We've talked about having all 7 board members. If more than 4 were there, I think as long as there isn't any voting going on, you know, it's not going to be an issue. So in the past, I've always been sensitive. Oh, we're going to have more than 3 board members, but I was corrected on that. And so want to put a pitch in to ensure that that we're giving you the opportunity to understand from the Wyoming Hospital Association and other boards that are going to be there the challenges that are facing hospitals in the state of Wyoming, and the help that the Wyoming Hospital Association wants to provide you. So please let us know as soon as possible. If you can't, we perfectly understand, but obviously I need to put a pitch in to encourage it. Okay?
Okay. Anything else, Sandra, that I missed? Let's take our 5-minute break before executive. We need to have vote to go to
I would do
executive.
your motion before.
Oh, that's right.
But you're still on.
Let's do the motion, go into the executive session.
I make a motion that we go into executive session for the purposes of real estate, financial, litigation, personnel issues, and real estate and credentialing.
It just says that.
We have a motion. Have a second?
Second.
Second by Cole, moved by Clint, on the executive session for appropriate matters. Although, any further discussion, all those in favor? Aye. Any opposed? Now it's a 5-minute break, or 7. We'll see what it takes.
Person trimester, I think that's what it's called.
Oh, so it just started.
Oh, it just started. It just started. So it's like a whole